All right.
Oh, you want to do the introductions?
Yeah, so we'll go ahead and start with introductions. I'll start since you're going to be speaking. So hi, everybody. My name is Jen Schierer, and I'm one of the product advisors at Vizient. I work with the clinical database. I've been working with Vizient for going on 4 years now. I joined from a hospital organization. I worked in quality. I'm a nurse by background, worked in quality in both the inpatient and the ambulatory setting. Our hospital was just getting the CDB as I was leaving. So my training really was as a product advisor and learning the tool, but really happy to be here today to help all of you get a better understanding of the tool. Dorothy and I are colleagues. We're tag teaming today. So you're going to hear both of us between today and tomorrow doing different parts of the training session for you. So glad to be here.
And I'm Dorothy Beck. I'm the product advisor, CDB product advisor assigned to OU, to your system. And they're like, Dorothy, you need your manager to come with you. So Jen's my backup because I've only been to with Vizient for like more than a year, but I've been using the CDB as an end user my prior Vizient life. I was the CDB coordinator and as a performance improvement specialist. And so I really like Vizient that I worked for Vizient. But I'm really glad that we are starting with, should we go through, the agenda for the first 2 days, right? For the 2 days. So we should go to so we're going to do risk methodology today. And I'm really glad that we're starting with risk methodology because like I said, when I started as a performance improvement specialist, that was like my focus. I didn't learn anything else but the risk methodology. And so I understand that you guys have completed the orientation, right? Most of you probably, and did the on-demand learning program level 2. And that's awesome, because not everyone does that. Your training program is really good. So I can tell you guys are gonna go places with using your CDB data with your performance improvement. So that means that is this a super user training, right? So you're ready for the next level, being your super user of the tool, and then start working on your performance improvement initiatives. So you are on the right track for that. So we will begin with one second, it keeps going to mine. I'm going to minimize the Zoom here. We will begin with a brief overview and figure out to let you know why we risk adjust. Why do we do things a certain way? Why do we do our risk adjustment a certain way? Our risk adjustment principles and how we construct our risk model process, the model population, and then candidate variable selection, and then our statistical models to get our expected values. And then the additional metrics that we created leveraging our risk methodology, like our Vizient acuity scale and relative expected measures. And also we will be spending time with our frequently asked questions or just scenarios. And as well as I will highlight specific resources that you can use in the Learning Center. In fact, I will point out where you can find those resources or documents that I'll be referring to during this session. So again, within the CDB Learning Center, if you go to the resources section, you scroll down, and then you click on the risk adjustment methodology tab, and then you have the option to select the previous version or the current version, which is 2022. And it will list all the risk adjustment resources that are available to you. So we have the tools section, the reference materials, and the risk models. And then in the reference materials is where you will find the risk adjustment methodology document. So make sure you are very familiar with that document because everything that I'm going to cover will be in there. And then make sure when you're, because I know that you have AMC, you're using AMC and community. So when you're reviewing that document that you are selecting the correct cohort because there's different versions for that. So with that, let's start by talking why risk adjustment is important, why we risk adjust. As you can see, when presenting data I know most of you here are you present data to your stakeholders, and that most of you would have heard these conversations. So hospital A, for example, has a mortality rate of 1.6%. Well, it says, of course, that's pretty accurate. We emphasize quality of care. Our low mortality rate reflects the excellent care our staff provides. Meanwhile, hospital B, their mortality rate is higher at 2.5%, but then they'll say, well, our patients are sicker. So that's what prevents us from getting stellar mortality rates, even though our staff provides excellent care. So we hear that a lot, right? But as you review the profiles of these two hospitals, you see that some factors that were out of the control of your hospital. So hospital A probably has the features of your Edmond Center, a community hospital, smaller patient population. Usually they come in for routine procedures, and then hospital B, in contrast, is more like the OU Med Center, a typical academic medical center in an urban location, has a much higher patient volume, diverse patient population, and many come in for urgent or emergency conditions or procedures. So as such, the number of expired patients is higher, or 2.5% of their patient population. So if you look at the observed mortality rates, hospital A is doing better than hospital B. However, as you learn more about our methodology, we calculate the expected risk of death or the probability that the patient will die given the patient's pre-existing conditions. So using our methods, we anticipated that hospital A should have fewer deaths and mortality rates should be around 1.4%. So, and then hospital B could have had more patients expire at 2.7%. And we look at that mortality index, which is how we present this information observed over the expected. When we look at the mortality index, actually, hospital A is performing statistically worse than hospital B, not like what we presumed. So that's why we're risk adjusting. This will allow our members to compare across many types of patients and providers, level the playing field, get an apples to apples comparison, and we put patients into clinically homogeneous groupings. And we use your administrative billing data. And so that's another important thing that we need to keep in mind, that we are using your billing data. We don't look at your EMR, we don't look at your orders, we look at your billing and coding. So we update our risk model every year to make sure it reflects the current hospital membership. And our goal is to encourage appropriate clinical and relevant coding practices. Do we have any coding professionals here, specialists, CDI? No. Okay. Well, I suggest you become best friends with those people.
You aren't already. If you aren't already.
Yeah. Yes. We also apply a comprehensive statistical methodology to ensure that it's actionable when you are looking at your data. And of course, like many other methodologies we provide, our risk adjustment documents are readily available for your review, and we get feedback from our members. So that's why we keep changing. That's our job.
Security.
I'm going to stop you there for a moment. We can have a chat.
Okay.
For our system that uses both academic and community for the different facilities, how does it work when looking at the system data?
We usually would suggest that we look at the AMC, right?
Yeah.
You can only choose one radio dial option, as you all probably know, in the functionality. So as a system, you probably, from a data governance perspective, want to decide when we're looking at the system, are we going to run community or are we going to run AMC? They are different. I mean, there is that, as you all know. So it's
AMC is what Dr. Lofgren has directed us.
Okay.
So currently we evaluate 3 outcomes for risk modeling. So mortality, length of stay, and direct cost. So notice readmissions is not there. We get that questions a lot. Why don't we risk adjust with readmission? So that's because we don't have enough data yet to do that. And these measures focus on inpatient hospitalization, defined as the time of inpatient admission to discharge from the same facility. We now have systems readmission that we're going to talk about, but for this purpose, it's in the same facility. So inpatient admission to discharge from the same hospital. And here we give you the definition of our observed values. As you can see, we use these formulas. Don't worry, we're not going to ask you to calculate this. We just provide you all the calculated values because it helps me when I was figuring out what does observe, how do Vizient define their observed values. So we measure mortality in aggregation as a percentage or rate, and length of stay and direct costs as a mean or average in terms of number of days and total dollars. And we define inpatient length of stay as the number of whole days, not fractions, between the admission and discharge dates. That's another common question we get a lot as well. So not when they arrive in the ED, but when they for the official admission date, inpatient admission. And the minimum length of stay will always be at least 1 day, even if the patient was admitted and discharged on the same day.
So just a quick question or clarification on the length of stay. I think I heard you say that we're looking at a full day versus a fractional day. Is that correct?
Yes.
So are just using traditional arithmetic routing
Yes.
tools? Okay. So one of the things that we as a system are primarily looking at is being length of stay, being able to compare that to the length of stay. Those numbers are reported. Also, how do we decide those two things that we are trying to doing?
I think it's an average for the aggregate data. It's an average, but for patients, it's right.
Well, and for GMLOS, there actually is the ability to pull that in as a data point in our patient outcomes report. When I cover report builder in the next section, we're going to talk about this add, arrange, remove columns feature, and there is an option to look at GMLOS in this same population. So you could have that as a column item.
So
in your.
I think my concern is that geometric name like to say first or DRT being we're getting just limited to a whole as opposed to a fractional. We may be at 3.6, but we're showing 4 because that's how the data is being reported back to us. So I guess I'm moderately concerned that it's just going to potentially throw up red flags where there may not need to be some, and it may, conversely, right, if we're seeing 3.4 is the value, but it's showing us that our average is 3 because it's rounding down, we may not see red flags where maybe we should have identified an opportunity for improvement.
Okay, understandable. Yeah.
Yeah.
So that's why we actually mentioned that because of that.
Okay.
I think there is the option though too to decide from, again, a data governance perspective, what if you want to constantly pull in GMLOS as your data point, because you can run that in comparative fashion too. And if that's a metric that you want to report instead of the mean, certainly that's an option. Just know though, for our index value, it is, the index is going to look at that average or mean for the observed when we look at the observed to expected. So when we're looking index wise, that will be, that will be what that's representative of. Does that help?
Not necessarily, but
Yeah. Yeah. So that's why GMLS is just an option. We don't use that as a part of our Vizient metrics. All right, so we talked about how we define and derive our observed values, and now how do we derive our expected values? So first thing we do is construct our risk models. And as I mentioned, we update our risk models every year. We look at 2 years of retrospective and patient administrative data. We separate the academic and medical centers into one model and community hospitals in one bucket. So like as you see there, 11.2 million encounters for AMC and 8.8 million encounters for community. And we'll look at rolling 2 years of data to minimize population variability. And then we immediately exclude some data contributing to the risk modeling process. So we exclude bad data, we remove transfers out, and then we ignore most ICD-10 codes that are not present on admission. And then we copy this data set 3 times to get mortality, length of stay, and direct cost modeling. And we recognize that there are instances beyond the hospital's control. And to ensure the stability of the risk models, we take out length of stay and charge outliers for the length of stay and cost metrics. So now we have come up with 6 models, 3 outcomes for the AMC and the community populations. And then from there, the data sets are further broken down into adult and pediatric modeling populations, and then into different model groups. And after that, we take our candidate variables and apply those to the modeling data set.
Quick question, I don't want to slow us down, but you made the comment about filtering out data for diagnosis sets that are not, for example, vision. I do see a quick note down there. Primary diagnosis is included regardless. So within our hospital system, particularly because of our relationship with CDI, we are constantly trying to update those, of course, to ensure appropriate coding, so we're getting reimbursed well. So I just want to make sure we're on the same page. If they change the primary diagnosis throughout the length of stay, we will see that reflected, even though the ICD-10s are excluded that aren't on that vision, correct?
Correct.
Yeah, we get your final billing data.
Thank you.
We did have, I don't want to steal your thunder.
Yeah.
We did have some updates though this year based on some new coding principles around codes that have a both chronic and an acute exacerbation phase. And so Dorothy's going to speak to that, but that was a major change and departure from our methodology to be able to include those codes that are irrespective of POA, yes or no. So she's going to get there, but so yeah, kind of a little caveat to that. We've always been able to say it must be POA, yes, in order to count in your secondary variables and your secondary diagnoses, I mean, but now that's obviously changed a little bit too. So sorry, Dorothy, didn't mean to.
No, always steal my thunder. I'm okay. So we talked about how we come up with those 6 risk models and now how models are contained within each model. The adult encounters are assigned to a risk model group using one of the following, either a diagnosis code that's present or a procedure code, or perhaps an MSDRG, or now before it was just MSDRG, but now it's a combination of we also consider a combination of the above. For the pediatric model, primary grouping criteria differ for AMC and community risk models. AMCs are combinations of MSDRGs, and community pediatric model groups are primarily grouped by MDC, or major diagnostic category. And exceptions to the primary grouping method are for the non-normal newborns, which I've listed there. And most of the model groups are primarily grouped by base MSDRGs. Remember, we strive to provide clinically homogeneous groupings, and we have limited data because we only have your administrative billing records, and our answer to group clinically cohesive groupings is by MSDRGs. Again, your coding and CDI can speak to that as well. So when we talk about these model group assignments, there are 3 major steps that must happen first, and they're listed here. So let's start with the first step. The first step is what we refer to as temporary regrouping. So in some instances, the CMS assigned MSDRG does not align with our clinically homogeneous principles. So what we do is we regroup these patients, particularly the ECMO or tracheostomy patients in MSDRG 3 and 4. And to regroup these cases, what we do is the procedure codes driving MSDRG assignment are temporarily removed, and those cases are assigned a different MSDRG. So for your cardiac surgery patients, take note of this, because most of their, if they're on ECMO and tracheostomy, most of their patients will be regrouped. So it's important that you need to learn that we do this step first. So after that, once the expected values are generated, the procedure codes are added back, and then the patient is reassigned to the original MSDRG based on the grouper that you've used. After we've done the temporary regrouping, our next step is to evaluate encounters looking at those procedure or diagnosis codes listed here, which would then place them in a model group based on these conditions. Encounters meeting the ICD procedure codes inclusion and exclusion criteria are assigned to a procedure model group regardless of the MSDRG assignment. And those procedures are listed here. For example, your THK procedures, your cabbage procedures, and your cardiac valve procedures would be most probably will be in this model group because of the procedure code that was present. We also have model groups that use diagnosis codes for assignment. Examples are aortic aneurysm model group that's based on the principal diagnosis of an aortic aneurysm. So there's a lot of caveats. So, and we're really glad that we've made this simple, right? Because it's really hard for me to grasp at first. So we're not looking at MSDRG anymore. In this step, we're looking at that principal diagnosis. And another common example is our COVID-19 model groups for both adults and pediatrics. Again, we're looking at the principal diagnosis of COVID-19. And then if it's not the principal diagnosis, we look at the secondary diagnosis. And then we look at if their risk model MSDRG indicates that their primary reason for coming into the hospital was a COVID-19 infection. So another caveat there. And this is to illustrate the adult COVID model assignment for your review if needed. And here are the 11 MSDRG selected to represent COVID-19 infection. So if your patient had this MSDRGs, we assume that they probably were their COVID, it's probably a COVID infection. One other example for the diagnosis is our oncology model group. And this is something that you guys might be interested in. And this was a recent change, but we really focused on that principal diagnosis of malignant neoplasm or in situ cancer or any chemotherapy or radiation therapy as a driver for which model group that patient should fall into. Again, really getting into more specific to the types of malignancy and comparing similar patients. We did this just to, again, this is from a member feedback. So we made these oncology model groups.
For oncology, is it pediatrics and adults? Because
Yeah.
all the other ones that were labeled were all adults, just the 3 Ps. So oncology is big.
So, yeah. And this is for the oncology model assignment logic for your reference. So now we're at step 3.
Let me stop share. Yeah, let me stop share and figure out what's going on here.
Great.
Sorry, guys, I can't seem to get back to the multiple slides, so we're just gonna look away, look away. Oh, it really got far, didn't it? It did somehow. I'm not sure how.
Okay.
There we go. Oh, okay. I went too
Model
far.
group assignments. There.
Here we go. Sorry about that, everybody. Let me reshare for the Zoom folks.
Oh, you're not sharing. So we did temporary grouping, right, for that ECMO and tracheostomy patients. And then we look at procedure and diagnosis assignments. And now we're at step 3, MSDRG assignments. So we only do this if those 2 steps, if the patient or the encounter does not apply to those first 2 steps. So then we're going to look at the MSDRG assignments. As mentioned, we primarily use MSDRGs to assign encounters to model groups. Before, that's what we do. We didn't have the procedure codes. We didn't have all those other nuances. But so if you don't know about MSDRGs, that's what payers like CMS use to classify patients into clinically cohesive groups with similar consumption of hospital resources and length of stay patterns. And sometimes it depends on your MSDRG on how you get paid, right? And then base MSDRGs are a combination of individual MSDRGs for the same clinical condition or procedure, regardless of the severity. So in this case, we see 3 MSDRGs that are all extracranial procedures with different varying levels of severity. If a patient had an extracranial procedure without a complication or comorbidity or major complication or comorbidity, that case gets assigned to the lowest severity MSDRG, which is 39, the last one there. If the encounter had a CC, then it would be 38. And with MCC, that would be the highest severity, would be 37. So while all of these have distinct MSDRGs, they're grouped into the base MSDRG, the one on the right. So this is what we leverage when defining clinically homogeneous groupings. For the adult models, the base MSDRG will match the risk model group, both for length of stay, cost model group, and mortality. And the slide here is to tell you that this is the case for most patients, but in some cases it will not match. And so we have in our learning center document called Variables and Coefficients Excel document, and it will tell you the mapping of the MSDRGs to the model group.
Yep, that document will be your best friend. If you
Yeah.
really want to get in the weeds with our risk modeling, you will know and love the risk variable definitions and coefficients document. It's a Excel workbook. It's a great resource within the Learning Center. We recommend you upload it to your desktop for ease of access, but do know that it gets updated annually. So whenever we release our new risk models, make sure if you've done that you have the latest version available.
And just FYI for everyone, it's also linked out on our the hub. On
Great.
the little quality page, we have a Vizient section, and I put it there also with that
Wow.
caveat on my calendar that I did that.
Oh, wow.
Another shortcut for you.
The other quick, we can go back to that last slide. I just want to make sure I'm on the same page. I'm thinking back to that first example, hospital A and hospital B that you shared with us. Hospital B says, we have more severe, and so that this is a really clean example of differences in severity. So, just to make sure I'm staying engaged, the MSDRG is what you're utilizing to help separate that. So risk model, you're using the MSDRG.
Primarily
Okay.
base MSDRG.
Okay, fantastic. Just want to make sure I understand.
Yes, in the majority of cases, but what Dorothy stepped through, there are those caveats. So if it's MSDRG 3 or 4, we're going to regroup those out. We take out the ECMO code, the trait code. So that's one caveat to this. And then the second caveat is if there were particular diagnoses like COVID or particular procedures,
Yeah.
then the MSDRG is off the table and it's the procedure. So those are the caveats. That's why it's like kind of like okay, step 1 was the case this or this, nope, this, and then ultimately it goes to DRG is kind of the best way to think about that.
And that's again from member feedback, because you're like, oh, it's space MSDRG. Yeah. So, yeah. Again, our job security. We continually change and we get member feedback. We take that into consideration. And so the data sets containing patient level ICD-10 codes, patient demographics, and many other data elements are evaluated. And here's a short version of how we assign the different modeling methods. First, we check if the model group meets the minimum requirements for regression modeling. If yes, does it meet the minimum criteria? If so, it goes to the final review of regression models. If not, it goes to the mean stratified model for the final review. So we have 2, and here's a more detailed look at our 2 types of statistical models. Logistic regression is for those model groups with adequate population size, at least 30 deaths, so minimum of 30 deaths, and they perform well statistically. So if you meet these, and then you perform well in our statistical, mathematical, whatever they do, you go on the logistic regression model, which is primarily, that's what the models go to. And then we run the models and produce these numbers for you at the bottom there. That's just an example. So you can see there are risk variables right there. So those are the different variables contributing to the patient's expected value that we determined statistically significant. And then another model type you see here on the right is called stratified model groups, also known as mean by MSDRG / number of ARC comorbidities. And these do not meet the criteria for regression modeling. So not enough case volume, low number of deaths, and statistically they don't perform well. So it's a challenge to come up with the risk variables that's on the left. So that's why we use the ARC comorbidities. And we, if you're not familiar with that, it's the Agency of Healthcare Research and Quality comorbidities, also known as Elix-Hauser comorbidities.
So the, what you're seeing on the left,
Mm-hmm.
that is also included in your, they were talking about workbook. You can go in there, find your grouping, and then there's another spreadsheet on there that you can look all of these up.
The definitions, yeah, these variables are all what we call buckets. You know, they're kind of like a bucket, but within each of those variables is the actual ICD-10 code that would drive that value to count as the expected value for the patient. So yeah, we drill that for you all the way down to that ICD-10 code.
So yeah, mostly that's for the logistic regression, but for the mean stratified model group, we just count your Elix-Hauser comorbidity. So the more comorbidities you have, the higher your expected value will be. So it doesn't matter what kind. Like, for example, VANT on admission day has a high, more weighted than the others. With ARC comorbidities, we just count how many.
And there are definitely more of the logistic regression models. So, you know, that's Vizient's way of really granularly getting down to looking at risk. Like Dorothy said, from statistical principles, our team that develops our risk models, if they can't come up with the statistical analysis because they don't have a large enough N or there weren't enough deaths in that population of patients, then we leverage the ARC comorbidities as kind of an alternate. But you'll see in our model groups, so there's over 900 model groups, like Dorothy mentioned earlier, the majority fall into this more granular model.
So we've discussed how we calculated the observed and expected values, that we have risk models, model groups, and then risk variables within model groups. And each risk model has its own diverse set of associated risk variables, like we mentioned, and they're going to be different from model group to model group. And our models are built to capture meaningful and clinically relevant conditions and comorbidities at admission. So if that happens after admission, that's a complication now, right? So we're not including those. So things that we include in the variables are right here. So we take ICD-10 diagnosis and procedure codes into account. We'll also see some of the procedure codes based on timing. So this is where we looked at whether the procedure was done on admission day or prior to another procedure. And that's just an exemption for that. Another patient level, other patient level information like age, gender, socioeconomic status. We take that into account, some, but not all. We also look at things like admit source and admit status, again, based on your UBO4 administrative billing record. And when we run all these variables through the statistical process, I also mentioned that they need to be statistically significant to be retained in our models, because we get that questions a lot too. How come this variable is not in this model? Maybe that because it's not statistically significant, or it's a new code that's not on our risk model yet. We do have challenges in our variable capture. Data elements we don't include at this time are patient factors such as genetics and health literacy, and clinical results such as vital signs and lab values. And we know, again, coding guidelines can change, so we take those into account. And our analytics team is really on top of making sure that's updated as soon as they can. All right, back to those risk variables. So let's start with those defined by ICD-10 diagnosis. And what you see here is a screenshot of the risk model variable definitions. Like Jen mentioned, that should be your new best friend. and we're going to show it to you if we have time later, but this is filtered for the risk variable of malnutrition. And we intentionally use this example because malnutrition is our most frequent and highest weighted risk variable. So if you're into mortality, they first make sure that their malnutrition program is up and running. On the left side, you see the variable description of malnutrition. And then over on the right side are all the associated diagnosis codes that Vizient would capture as contributing to the variable of malnutrition. So like Jen said, and I think Bobby also said that there's that document has hundreds of other diagnosis variables, and later on we'll try to show it to you. But most of these diagnosis codes for our risk adjustment methodology must either be the primary diagnosis or designated as POA yes. And POA yes, Vizient defines that as either yes, Y yes, W, 1 or E. And we have a slide with the definitions of this that I can show you later, but basically I think exempt E is exempt. Because historically documentation of our present on admission yes has been the fundamental concept when we're dealing with our risk variables. So notice, and Jen alluded to earlier, we say most diagnosis codes must be POA yes with a couple of exceptions, and let's go ahead and talk about that. First is our DNR variable. As we know, DNR used to be the only variable that did not require a POA yes criteria. However, additional criteria are needed for that diagnosis to count, and the actual variable description is DNR without vent greater than 96 hours or ECMO. Actually, it's just not DNR. The rationale behind that is that sometimes the patient does come in very sick, but the DNR cannot be obtained until a few days later or after a few days after the admission. So we want to exclude situations where the DNR is really related to later withdrawal of life-sustaining care. So if you come in as a DNR, let's say you have you've been a frequent flyer, for example, and you've had a DNR in the past. So we take that into account, but we just couldn't figure that out with the billing, coding billing. So that's why we added without vent more than 96 hours, and we don't look at your present on admission status there.
And I'll just mention too, it's definitely the code has to be on the record. So I know in our EMRs now we have alerts, this patient's a DNR, but if that's not coded in the billing code, the Z66, that also won't count towards the expected value for Vizient. So yeah, just know that it's more than what's just captured in the patient chart, but actually coded and documented in the billing.
We get that question a lot.
The Z66 code.
Yes, ma'am. See,
we can check out the scenario.
We can actually use the CDB to check
later. Yeah, it's a scenario, I think, later. All right, so that's the first exception. And this is just to, and again, an illustration on how that variable is captured. So now, Jen mentioned this earlier, for 2022, this is a departure from our previous that we've incorporated here based on the AHA coding guidelines, which state that you should assign no if at least one of the clinical concepts included in a particular code was not present at admission, and assign yes if all of the clinical concepts included in that specific code were present on admission. So this pertains to those chronic conditions that also have a component of acute exacerbation. So from a Vizient perspective, we recognize that those that are chronic conditions should be contributed to the expected value. So what we did as a result of the new coding guideline, we will now accept those codes to trigger as a risk variable, regardless if they're POA, yes or no. And these are the variables that will now be accepted with any POA indicator based on that AHA coding guideline. So let's take this NEPOA indicator example of alcohol abuse. So according to the coding guidelines, if a patient with alcohol dependence goes into withdrawal during the admission, the code, which is F10231, would be reported, but it would be reported as POA no. So if it's before, we're not going to count that, but now that no, I'm talking about the withdrawal delirium that's present at the time of admission. So with the new methodology, what Vizient did was, if the alcohol abuse variable is there, that code is there, it would be triggered for that model, even though the POA indicator was no. And when we look at this in the variable definitions document, again, what you're seeing here now is that it's filtered for that risk variable of alcohol abuse on the right, on the left. And you can see that the ICD codes over on the right side are what define the variable. However, we made it very easy for you to recognize these codes. And now it is with that blue font. And if you see at the top there, the description, it will tell you that those that are ICD codes that are blue, we will take any POA indicator as a variable.
Any questions on that? It's a little, I know it's a little tricky, but it's just those very specific codes that AHA released the new guidelines. And so again, Vizient's answer to that, we wanted to be able to capture those in our risk methodology and have those trigger and, expected value, even though it was POA no based on the AHA coding guidelines. That's the goal. Yep, exactly. And to get those expected values as robust as we can.
All right, so we talked about diagnosis codes. Let's talk about the variable definitions based on procedures. In this example, it's filtered for the variable abdominal wall repair. And if one of the risk variables on the right or risk ICD codes on the right are in your encounter, that would trigger that because it says any procedure, so anyone. And there are procedure risk variables that are also a little bit complicated, just like the DNR, that are based on formulas. In the example at the bottom, you can see it's a Whipple procedure involving 2 organs and multiple ICD procedure codes. So we use the additional criteria, the column on the right, to show you what that means. So it has to be RM 2021 should be a 1, which is yes, and 203 also should be a 1 for that variable to count. All right. We're good so far? What time is that? Time check. All right. So once the models have been finalized, expected values are calculated and assigned to all patients in the CDB for each outcome. And we have certain rules that must be applied. Again, first, present on admission criterion does not apply to the principal diagnosis, only the secondary. And those specific codes I mentioned will be accepted for any POA indicator. And in some, more than significant variable within the same model group may have the same overlapping ICD codes. If that's the case, all significant variables with the same codes will contribute to the encounter's expected value. So you can double dip. And the new ARC-CC definitions now include specific secondary diagnosis not present on admission for those means models. I know this is a visual. I love this. This is a visual of our expected values calculation. For the regression models, the left is for mortality and the length of stay on the right. And what I really want to point out here is the intercept and the beta coefficient. They're both in the equations. A beta coefficient is a weight of the particular variable's impact on the expected outcome that you're looking at. So the higher the beta coefficient, the higher is the weight. And then a question we also often get is the intercept. And you'll see that in the calculator, I'll show you later. The intercept is often labeled as the constant, a starting point of risk. And you may also think of this as a population baseline or a cohort average.
We're not going to test you on that equation.
No. And don't ask me about the occasion. So to illustrate, a 50-year-old male patient presenting with fluid and electrolyte disorders came in for repair of his ventricular assist device. So he falls under the AMC mortality model group. Hopefully your VAD patients are not in your Edmond Center, right? And that comprises MSDRG 1 and 2. So let's figure out the expected mortality value. First, identify whether each variable was present for the patient. And if the variable is present, it receives a value of 1. If not present, its value is 0. Again, the intercept, the very first row there in that table, will always be negative. And as you can see, some variables have negative coefficients, like these last two here. Yes, thank you, Ivana. A negative beta coefficient essentially means that it has an inverse relationship. So that means reduced length of stay or lower costs and decreased risk of mortality. And then so using the formula, we have the expected value there on the right. Any questions on this?
It's really in the
how, yeah,
weeds.
Yeah.
It's in the weeds, but
Super helpful for us then.
good. Okay.
All right, so occasionally, like I said, the regression model, most of our patients will go in that model. So if the encounter goes into the stratified means modeling, remember the low number of deaths, low volumes. In this method, we look at the number of comorbid conditions, which are predefined diagnosis code sets from ARC. And we use ARC because it's transparent. We can tell you what diagnosis codes are mapped. So for example, for this model group, patient MSDRG 934, right? Full thickness burn. It's assigned to model group 319 based on the MSDRG, for example. And so according to the table here, if you have, let's say the patient has 6 ARC comorbidities, then the patient will be assigned an expected mortality of 0.032 based on that table. And every encounter has expected values. This is a screenshot of our case profile report with an encounter falling under mortality model group 1. And as you can see, we have expected values for the 3 risk-adjusted outcomes. The same logic applies to pediatric models. So those that are highlighted there, those are expected outcomes for mortality, length of stay, and direct cost. Now let's talk about making comparisons among groups. So the way our risk-adjusted metric is reported is an O over E, or an observed over expected. So you know now why I'm going to this, right? I talked about observed values, expected values. So observed over expected is what we call an index. So anytime the observed is less than expected, the index will be less than 1, which is a desirable outcome. As you can see in the teal box. It means the hospital experienced lower costs, fewer deaths, and a shorter length of stay than expected. Now, occasionally, the O over E ratio is equal to 1, in which the observed is exactly what we have predicted, purple box. And whenever that index is more than 1, green box, the hospital has opportunities for improvement because their observed costs, direct cost, death rates, and length of stay were greater than we predicted. So based on those values that we talked about. Now, how many of you have encountered a report output like this? I like to point this out because I made this mistake, where the mortality indices were through the roof, even in the double digits, right? There's 52.96 mortality index. And then your stakeholders were like, no, I don't trust this data. We only have 1 to 3 deaths. I don't trust this data. Why are our mortality index like that? It's because I should have not used mortality index when showing them the data, because the cases are less than 25 and it's a small population, and we do not recommend using the indices. That was before I attended the risk methodology. So now I know. So we advise evaluating O2E ratios or mortality indices at the service line or the hospital level versus the individual patient level, as ratios are designed to assess observed expected values in aggregation for statistically comparative purposes. If you cannot, you need to make sure you have an adequate population. You can maybe increase your time frame to get more than 25 cases. So before I was showing them like aortic aneurysm cases, less than 25 in a month. So what I did, I just increased the time frame to instead of monthly, quarterly. Then you can see here for our example, we have 5 patients. No death, looks good. 1 death out of the 5, suddenly your O/E ratio is 2.36. So bottom line is mortality index can spike with low volumes, 52 point something. You need enough cases to ensure reliable estimates. All right, and here's another thing I want you to take into account. So instead of aggregating, instead of looking at it in mortality, less low volume cases, you want to aggregate to look at a group of patients. So let's do that. So this is a patient outcomes report by Vizient service line. So before I was doing it by principal procedure physician or something like that. So I made it into Vizient service line and I'm looking at groups of patients. So general medicine case number is almost 3,000, the rest in the hundreds. So this is a good one for mortality index. For the observed and expected values, we take all the individual values for the number of cases, and what you get is a mean length of stay for that group of patients, same with mortality rate and mean direct cost. You can see in our example here, our observed values divided by our expected value, which gives us our O/E index. And that's going to be calculated as we see right below. So with our mortality index, as you can see, we have 1 with no death, and most are more than 1. So most of the service lines, except 1, has opportunities for improvement. And then all service lines, as you can see, they have longer length of stay because it's more than 1. And for most, their cost is better than expected. The question is this hospital sacrificing quality over cost? So that's something that you need to look into. So that's why we give you all those 3 metrics there.
I'm going to go back for 1 sec. Just so everyone knows too, that expected value, especially when we look at mortality, that percent deaths expected is not only looking at these 114 deaths, it's actually calculating the expected value of all of those 3,000 cases. So when you're looking at expected, it's not going to be the roll up of just the 114 that died is your expected value there. It's your denominator base of total volume, if that helps too.
All right. Thank you, Jen. So now you might be asking, and I'm going to go through this really quick now. If you can't use O/E metric for populations less than 25, what should you use? That's where our patient level comparison comes into play. We have our relative expected measures, which compares the observed value, your expected value, to your mean observed value of the model group. Okay, so it uses the model group mean observed value. And then the Vizient acuity scale uses the overall Vizient inpatient population. So let's start breaking. So the relative expected calculation, I know I like the calculation because that's how I get to understand what's going on in there. But the categories are assigned or calculated on this table, comparing the expected value to the model group's mean observed value. So we've got our scale from well below to well above. So we take that model group's mean observed value, and then we plug it in here, and then we do the calculations. And then we'll look at here to illustrate. Let's use the expected value, for example, in the orange box. And that is our, this is a case profile report, right? And this is the mortality expected value of our patient. And then the group are assigned the encounter to MSDRG, which then gets assigned to mortality model group 1. And we know that the model mean observed value for that model group is in the teal box. We plug that number in here, and so you get the results on the right. And now we go back to the mortality expected value, that orange box there, and then we look at where that value falls, and that's how you get the below category. And that will translate in the case profile. If you look at that top right box, it says below. in the purple box there. And here's another way of looking at it. So let's say our patient's only risk factor is a male and he's less than 55, is going to fall on our scale here under below category. And once you start adding things to the same patient, it's creeping up in severity, and expected value will also differ. And then this is the Vizient acuity scale, the same concept as relative expected measures, but we're looking at the Vizient inpatient population, the whole Vizient inpatient, which is how 11.2 encounters. So if you look at 2022, these numbers that you see on the screen here, that's constant. It's not changed. You will see that in all case profile reports. They're all going to be the same, even though they're in different risk model groups. So it's the same. So if you can just the same concept there, it's just a bigger population, right? If we want to go to the risk model calculator.
You want me to actually go in the tool?
I don't know. Let's look at maybe later when we do the, but this is just a screenshot of the risk model calculator. The first tab would be the instructions. I recommend reading that. The second tab would be the mortality risk model. And then once you open the mortality calculator, you will see the top section. It's telling you the model version, which is 2022, and what outcome, which is mortality, right? And then using the drop down, you can view any model group. Okay, and then you'll see the MSDRG codes and description detail for the selected model group. And then down here now, you can indicate with which of the variables are present for the individual patient. So by entering 1 for present or 0 for absent, you can also leave it blank instead of 0. The value for your intersect on the right will calculate. And then once you add those on the right there, it will keep changing. So if you, for example, see how your male age is it negative coefficient, it will also make your expected mortality in below category now, because you use that negative coefficient. So as you enter the values, the results columns, and this is where you're going to do your, when you're doing your mortality review, making sure that if this patient is in this model group, the variables are coded correctly. They are POA yes, if that's a criteria, that's a requirement, and that your then you will look at if it's below, you know, the different categories, if it is correct. If not, then it might be a coding opportunity. Okay, so that's what you're going to use to proactively figure out your coding opportunities. And then if it's also a documentation issue, because sometimes the coders will just code whatever is documented.
This is where our CDI folks come into play. They may not be running the same analyses you're running in Builder, but they might love this risk calculator tool, which is this macro enabled workbook that you can go in and again, do that plug and play. If this had been coded, what is the impact in that expected value?
So if you click on it, yeah, sorry.
Oh, you had little, sorry for, we're adapting to the technology here, Betty. So she had those.
So I don't know if we have time for an FAQ, but I think that's all the FAQs are in there, and then we tell you what the answer is. So these are the common questions that we get. But if you have any questions later at the end of the day, we can get to it.
Yeah. This deck, you guys will all have access to this deck, but these FAQs are really nice because we tried to capture a lot of the questions we get around risk variable capture and coding and documentation. So kind of guide you to those resources. The other thing, so all of the Vizient proprietary risk definitions are in that document that you referenced, that you have how. We also provide the Elixhauser definitions. They're just in a different place. So when you're in the resources section in the Learning Center, that's at the bottom of the page. Instead of risk methodology, if you go over to the tab that says national codes and definitions and click there, you'll see a PDF. Actually, I think that's also an Excel document, but that's where you'll be able to see the Alex Hauser definition. So again, from your coder's perspective in the calculator, if they're using one of the mean stratified models and needed to know how many ARC codes were present for the patient, they can source that definition document as well. It's just, it lives outside of the Vizient risk modeling because it, you know.
And this is how you get to it.
Oh, thank you.
Mhm.
National codes definitions, and yeah, Alex Hauser comorbidity definitions. And we update that when Alex Hauser does their updates too.
All right, what's next on the
Report builders at 1:15. So if folks need like a stretch break or a bathroom break, we can answer any other questions you might have. Risk is heavy. We start with risk, and I know it's heavy, but I think it kind of sets the foundation.
When I were trying to go through to, Christina had sent Facebook presentation, you're trying to reproduce something. And we've met with her since then. We got into it.
Yeah.
I played around trying to figure out, so we had opportunity.
Yeah.
For
That's always a great starting point, is coding and documentation, right? Because you know, how are you going to change your index? You're either going to drive your expected up or your observed down, or ideally both. But observed down is the harder picture, right? That's processes, that's, you know, clinical care, you know, care pathways, how we accept transfers in, you know, all that, which is like that's your job security, right? Right. Coding and documentation, that's sort of that, we call it the low hanging fruit sometimes, but
so that's why you start there first. All right.
So I'm gonna just keep sharing and I'll go through my slides, which will be brief, and then I'll show them in the tool, some of the things I want to show. I think it's better to be live than in the slides. I do need to run. I think we're just the rest of them here.
Oh, to the left. Yes, I know.
Yeah, we got a thumbs up.
Got a thumbs up. Awesome. Okay. All right. Well, hopefully you all had a good chance to stretch and clear your heads a little bit after risk. Risk is heavy. We were talking about that. It's very heavy, but it's also really foundational to understanding a lot of the data outputs that you see from the clinical database. So with that, we're going to turn now to Report Builder, which again, I'm going to make some assumptions that all of you did attend our basic orientation training. You've seen the levels. So have a basic understanding about how Report Builder works. If there are some questions along the way, though, don't hesitate to pause me. I don't want to make too many assumptions and move too quickly, but we are going to cover maybe some more advanced topics than what you would have seen in the basic orientation. So if you remember, within CDB, Report Builder is where you can do all of your ad hoc polls, right? That's where you can customize your reports. You can create populations of interest as granular as, you know, populations based on a certain MSDRG or a certain diagnosis code. So we all love Report Builder. It's our favorite place to work and play. I will ask you all to log in to CDB just so you can follow along with me. I think that's the best way for everybody to learn, is to be hands-on. So if you are able to, go ahead and log in. And of course, just as a refresher, you know, from your main Vizient page, you will find under quick links, the clinical database quick link. So I'll give everybody just a second or two to get there with me. I'm going to be in slides for maybe the first couple minutes, but then I'll go to the tool myself, and then you guys can all follow along with me in the tool. We also have scenarios that I think, Tennille, did you send those out? Or okay, so you'll be using those kind of as a reference, and I have the slides with the scenarios too. So everybody good if I keep rolling? Okay. So I'm going to start with just, again, a couple overview slides. This is probably repetitive, but it just really helps us level set and understand, kind of back to Dorothy's point earlier about the data source for the CDB. So if you really think about how the data is coming into the database from your facilities, it's based primarily on that administrative billing data, right? So things off of that UB04 bill. So some very standard fields. What Vizient does is we create 14 different data files then that your hospital is submitting to us on a monthly basis. And when you submit to us monthly, there's a couple things to know here. It's based on a 30-day lag. Okay, so when you submit data to Vizient, there's that 30-day lag built in, because we understand, because it's so dependent on coding and documentation, that we want to make sure it's as up to date as can be. In addition to addressing that, we have you submit a rolling 3 months of data, right? So every month is essentially submitted 3 times, again, to capture any coding and updates and changes. And so back to that data governance piece, you know, talking about, I think, Tennille, you said, you know, one of your you know, thoughts is to keep, you know, that you'd have a certain month that, you know, you're always kind of looking at as your current month, because, you know, there's going to be some new reflective information if there had been some coding changes in the database. So I don't know if you want to speak to that.
I can just add there, that calendar submission, most of us here in quality were used to Premiere. We knew pretty much what that date was. Out on the web, on the quality page and the Vizient section, there is a submission calendar listed there. So that way, you know, like we always submit on the 7th of the month, but you know what packages we're submitting and then what our close, quote, quote, close data is. So that way, that means that we won't be reloading that particular month. So you'll always know what's up to date.
Where I don't know.
On our quality page under the Vizient information.
Cool. I love that. That's, I mean, it's so fun going to different facilities and hearing how you operationalize things. I mean, I think that's kind of the next iteration for Vizient, is really to help use best practices around things like that. So we'll probably be tapping into you guys at some point for some best practices there. So, all right. So then, in addition to what you're sending us from your administrative billing data, we also acquire data from 3 additional sources. So we get conferred rights, your hospital administrators assigned rights for us to go into the portal at the CDC website for the NHSN data. So those of you that are big patient safety gurus, you know, NHSN, National Healthcare Safety Network, is where you are able to report your CAUTIs, your CLABSIs, those events that are considered patient safety events. What Vizient does is we pull that data directly from that portal back into the database, and then through an algorithm matching the encounter number. Okay, so an encounter number from NHSN matched to an encounter number in CDB. So we're not doing any calculations. We're not using any of our own methodologies. That's literally your data that's in the NHSN portal, and we're pulling it back in. From time to time, there may be, because of that matching algorithm, there may be a slight case or two off if we're unable to match a case. Maybe for whatever reason that encounter didn't make it into the CDB, but it was in your NHSN reported data. I just like to call that out, because sometimes if you're really getting granular and saying, well, we had 3 in NHSN and only 2 in Vizient, that's likely the reason why. Okay. The second piece of conferred rights we get is, from a data perspective, is your HCAHPS, your patient experience from your patient experience vendor. This is done only at the facility level. So this is not done unit-based, it's not provider-based, it's not clinic-based. It's your facility, your Medicare ID for your facility, and it's not available in Report Builder. You will not find any HCAHPS related information there. The only place we report that out is in our major benchmarking report, 2 of them. The Quality and Accountability Scorecard is where you're going to be able to see your HCAHPS data, your top 5 box scores for the facility in a comparison with your cohort for Q&A, and then also in the VIP, which is another one of our management reports. There's some HCAHPS related aggregated information there. And then the third is core measures, and my apologies, I didn't do my due diligence to know how you are all doing your core measure. If you're
We're still using a different source.
a different source, okay. And are you conferring rights for that to come into CDB or no?
No,
Okay, that's the how do I explain this? So Vizient used to be a core measure vendor, and we actually spun that business off to Metasolv. They really played more in that space than we did, and so they're kind of our liaison. So anybody that has Metasolv has a way to get their core measures into CDB pretty easily, I guess, for lack of a better technical word. But if you have a different vendor than Metasolv, it's a heavy lift for your IT folks. So as of right now, core measures is not in CDB, but we're kind of moving away from even using core measures in a lot of our benchmarking data. We used to use it in our quality and accountability, and we've actually moved away from that for various reasons, based mostly on our steering committee input. But so not having core measures data in the tool from a Vizient perspective and how you do your benchmarking reports that we submit, that we send out, push out to you, you won't see core measure stuff there. We have a very specific core measure report that if you were submitting, you could leverage that, but that'll be for another day if and when you ever decide you want to pull your core measures in. Okay, so now the Vizient value add. So this is a pretty busy but important slide, because again, so you're submitting this data to us, but then what do we do with that data? What does Vizient do to add value that you're getting out of the clinical database? So the very first thing is, again, that risk adjustment methodology. So we're telling you, okay, from this data, we're able to connect you with your expected outcomes for those 3 major events: your length of stay, your mortality, and your cost, for virtually every encounter. It's rare that you wouldn't see an encounter that would have an expected value. Occasionally, if it's an ungroupable, if they can't get placed into a DRG or something like that, you'll see that from time to time. But for the majority of your encounters you're submitting, you're going to see expected values for those 3. We also calculate the case mix index, and this is based on the CMS grouper. So within the CDB, we actually have the software for the Medicare grouper, CMS grouper. That's how we figure out what MSDRG the patient is placed into. We leverage that. And so the case mix index calculation is that same methodology that CMS uses based on the weights for each of the DRGs to create your CMI. We just updated with the latest version. So we're using the 40.0 grouper that was released in October by CMS.
Just for clarity, we would expect that the CMI from Vizient would match that.
It should, yes. Additionally, we talk about readmissions. We have a whole session tomorrow on readmissions for you guys, but we talk about readmissions in readmit pairs. So we always will associate an index encounter with a revisit encounter. If that revisit encounter, if the patient comes a 3rd time, that revisit encounter actually becomes the index for that 3rd visit. So you actually have 2 pairs with 3 visits, if that makes sense. If you can orient your heads around that, we will always refer to them as readmission pairs, okay? Additionally, so your AHRQ, so again, back to that patient safety stuff. So patient safety indicators, your IQIs, your pediatric indicators, those are all calculated within the Vizient clinical database by the ARC software. We actually bring in the ARC software, and again, not Vizient definitions. These are all the specifications coming directly from the ARC specs for each of those patient safety events. We use I don't want to get too technical with you all, but we use a software version that's their SaaS version. There's 2 different types of software from ARC that you can download into your systems, anybody, it's publicly available. We use the SaaS version, which actually looks at up to 30 ICD-10 codes for inclusion and exclusion criteria. So that's another really important thing for you all, because depending on if you're, if you have an internal source system that's maybe using a different software that's, say, only looking at 25, CMS only looks at 25. Again, you're going to potentially see some discrepancies in those event rates or event numbers because of our having 30 inclusion and exclusion criteria codes, that might be able to capture an exclusion. Does that make sense? All right. We just launched last week the latest version of ARC. I know it came out earlier this year. It's a lot of back-end IT work that Vizient has to do to get that software in. So we just released the 2022 version. So you'll see that as a radio dial option on your report builder at the top of the screen. So you can use 2022 for ARC, for those of you that like to look at patient safety. So the next line item here is HACs. Again, these are based on CMS definitions for healthcare acquired conditions. So your CMS HACs are going to be calculated using their definitions based on that same grouper from CMS. The last two are Vizient defined. So in addition to your PSIs and your HACs, Vizient also came up with a subset of potential complications that you can track and trend. So things like in-hospital stroke, complications related to anesthetic. So you'll see those, again, transparently in our learning center. We have a definitions document where you can see what those Vizient specific complications are above and beyond what you're seeing from the regulatory bodies. So just another value add. And then the very last thing is the service lines. And again, I know all of you went through basic orientation training, but Vizient service lines, it took me forever to wrap my head around it, okay? Service lines are defined at the patient encounter level. So whatever patient MSDRG they're assigned to, again, it's nuanced because it's not a straight one-for-one DRG into a service line. Sometimes if they have a particular procedure present or something else, that will drive them into these Vizient defined service lines. You might ask, well, why aren't we doing it by how everyone else does? Specialty, physician specialty, and what service are they in? Well, if we don't exactly define them the same from hospital to hospital, when we're in a comparative database, you're going to be comparing different patient populations. So Vizient's solution to that is if we have Vizient defined patient-driven service lines, when you're comparing your hospital performance to a cohort, we know those patient populations are defined the same way. So, any questions at all about that?
Do you mind just giving me, I understand what you're saying. Do you mind giving me an example of?
Trauma is a big one. Trauma, I always use the, an OB patient. An OB patient might have been in an MVA, and she ends up in your OB unit to be monitored. But if there was a DRG that the MVA drove her into DRG, she's going to fall into our trauma service line, and not your OB, and not your OB service saw her here, but she'll be in Vizient as a trauma.
Right. So then I guess the question that I just want to make sure I'm on the same page. So thinking, connecting the risk adjusted in that Vizient service line. It sounds like, based on what you said, but if we're wanting to see how our, from a hospital perspective, what we would call our OB service line, we're wanting to see how they're doing in terms of she would have, that specific patient would not show up in OB's data, it would show up in trauma's data.
Correct.
So we may still have to do some
You can let that provider know.
understanding. Okay.
You can look, but you can segment by provider, you can segment by populations, you could define your populations by, again, I don't want to misrepresent the work involved. If you work with your coders and you know all the codes you want to see for that population, you can create a custom list that you then save. This is our OB population. You have that option too. But this is really more around our benchmarking, like the things Vizient pushes out to you to give you kind of an understanding from our benchmarking perspective. So we really give you an apples to apples comparison. So.
And we,
Something also,
no, go ahead.
I was going to say something also to keep in mind. There's been a bigger push to look at our reports more at a service line base, and the service line being the types of DRG, like for instance the OB trauma, that it may be hitting the trauma service line, but your physicians, you may have oncology physicians that are in that trauma, you may have a trauma patient, but as far when it comes to the specialties, you're going to have multiple specialties in there as well. That makes sense.
Absolutely.
And then another thing that you can use for physician attribution too is the physician role. So like discharging physician is a good one. And then principal procedure physician for surgical procedures.
All right. So a couple of tips. So here at Vizient, you guys that have been working in the tool for a while, you know that we're here to support you as best we can from a customer service standpoint. And many times, if you're really granular into a report and you're not really sure about the output you're seeing and you have questions, we'll respond with, hey, go ahead and share that information with me. But we're also so very hyper aware of PHI, right? I mean, this is patient level data sometimes. And so we have a secure way for you to share with us. So when we do our trainings, we always like to remind you of this one way of sharing with us, which is called the secure data exchange. It's basically a secure platform. It lives off of the dashboard page. This is a really busy slide, but if you follow the numbers. So from the dashboard, you would look for the secure data exchange option. And then you have to accept that you are sending secure data. And then in step 4, it's a really intuitive process once you're ready. So maybe it's an Excel file. Maybe you've run a drill down and you have a bunch of patient encounter numbers. We want to highlight this. We can't overemphasize the importance of sharing, securely with us. So that's one option. The next option, of course, is within the tool. This might look a little more familiar to some of you when you're ready to run a report. So over here with these icons, you'll see this little two-faced icon, these 2 people. We also have the addition now of these multiple people icons. I'll keep this as brief as I can for simplicity, but this first was kind of the legacy function is to share. So share allows you to not only share with Vizient, so this is a second way you can share with Jen or Dorothy if you had questions, but also can share with each other at your facility, right? Maybe Bobby's created a report she wants to push out to everybody and say, let's use this for our definitions for our population. So using this one that's circled share, I just want to differentiate the two. Share means that you're sending that report out, but any changes Bobby makes to that in the future won't be reflected in those of you that received it, okay? As an answer to that, a new solution from our strategy team was to come up with this other icon, the many heads. I don't know really how they came up with their logic for the icons. And we're still using a floppy disk for save in 2022, and nobody knows what a floppy disk is anymore. So anyway, the multiple heads is what we call distribute. And so we're really encouraging folks when you share to actually use that icon instead, because what distribute means is that when you share a report, any changes the owner makes to that will be reflected in the recipients as well. Okay, so just to differentiate those 2.
So if we've already shared it with our dashboards or something else, because we have created some dashboards that we shared and said distributed. Can you delete that?
Yep, I would just have your users kind of, I'm thinking of maybe a process. So have everybody go in and delete those. And then what you'll want to do, yeah, they do. Because once they've accepted it, it's sort of in their purview, it's in their inbox, if you will. So you'd have them delete that one, or you can name it something else. You can name it V2. I don't know, I'm just brainstorming some examples to maybe create less workload. Yeah, no. But then you would send it via distribute and then that, yeah. Okay. All right, promise I'm gonna get to the fun stuff, but one last thing I want to cover, and we briefly covered this in orientation, but I know we breezed through it. And this is for those of you data nerds that really like to get granular with your data and use and or statements. So I want to see patients that have XYZ and XYZ, or you know where I'm going with this, right? You can really get as granular as you want in your data query and your data pull out of Report Builder using this, what we call build expression function. Now, if you don't see build expression right now, a couple things. You have to populate some advanced filters in order to see it there, number one. So once you start populating some filters in, like I only want to look at patients that had this procedure, that button should appear. And when I say button, it's this green build expression. If you don't see that, it's actually, for whatever reason, I'm not sure why, but it's an access level. So you need to reach out, to the coordinators and have that level of access for build expression.
No, you should have that issue.
You should all have it. Okay, good. All right. So I just want to step you guys through real quick. Again, these are available for you as resources. These are some tips. Again, this is how you use those operators of and or. It's not dependent on case, so you can use uppercase, lowercase. That's not dependent on that at all. You do want to make sure you're using parentheses where it's appropriate. And I have an example, so I'll show you. It only accepts up to 50 character limit. So if you are a real data nerd and you have set up a really robust, expression, the 50 character limit does come into play. Okay, we do have an FAQ. I think I circled that in that last, when you're in advanced restrictions, that little FAQ link is there for how to do expressions as well. So here's a practice scenario that we show. Again, I don't know if this is real world or not. When we come up with our scenarios, we try to at least be mindful of that. But so you're asked to review the mortality index. So we want to look at the O to E ratio mortality for the 4 most recent quarters for patients who had COVID and also had pneumonia or sepsis or needed a ventilator. Okay, so that's our and or stuff going on there. So what we're going to do, again, this is, I'm going to breeze through this pretty quick. We're in Builder. We're going to pick a patient outcomes report. We're going to pick our date time frame. But then in the advanced restriction section, we want to start pulling in those diagnoses, right? So we want to look for that diagnosis of COVID. We want to look for that diagnosis of sepsis. These are all using our search feature within any diagnosis. So we can say, let's search for those COVID codes. We're going to populate the pneumonia codes. And we're going to populate the severe sepsis codes. So we've sent that all over into Builder. And we also did the ventilator. So now what you're seeing here in Report Builder is our list of advanced restrictions. We've got COVID, we've got pneumonia codes, we've got sepsis codes, and we've got those procedure codes for ventilator. Now we're going to build our and or expression. So we're going to click on that green build expression option. And what you'll notice when that happens is these circled filters that we put in place that now currently have check marks. When you click build expression, they're actually going to change to letters. They're going to become alphabetized, A, B, C, D. So now each of these filters has a letter associated with it. And that's the letter that you're going to use then to build your expression. Okay. So in this first example, what I did here was showed how you could set it up incorrectly if you don't use your parentheses, right? A and B or C or D. We need to give it logic. So the option to, before you run the report then exists to validate your expression, and you can click validate and the tool will say, are you sure you want this? Do you want A and B? Or, it kind of gives you a, hey, is this really what you wanted to do? So then I can say, nope, actually that wasn't right. I'm going to come back to this second example down here. And I've got it set up correctly now. We've got A, which is our COVID patients, and then in parentheses, if they had pneumonia, or if they had sepsis, or if they were on a ventilator. And I can validate that expression, and the tool will say the entered expressions are valid. So it kind of validates your logic. Okay. This is a really, really nuanced, very granular thing, but we like to show it in advanced training because, again, there are really circumstances where you may want to do that with the data, right? We're not just so singular focused with what we can pull for our population. Any questions about that? I breezed through it pretty quickly, so. Okay. All right. So again, this is just a larger view of that. Okay, so now the fun part. We're actually going to go into some scenarios. These are kind of all over the board. We're going to use different functionality within the tool and show you different ways that we can set up these reports. They were sent out to you via slides. So if you can kind of bounce back and forth, do you have handouts or no? Is that,
No,
we don't have enough. Okay, okay. And we'll read them to you too. So we'll, yeah. I have it up here. Here's the challenge I'm going to run into. I actually want to go into the tool and show you what I'm doing in the tool. Yeah, so maybe if you guys partner up and one have the scenario open, one have the tool. I don't know how you probably all want to be hands-on though in the tool. So yeah. You know what? We can both share. Except that's going to mess up Zoom. We can both have our little screens up, but I think Zoom might not see it.
No, I think I've seen it earlier.
Okay, let's try this. Let's experiment. Folks at home, forgive us if we.
We didn't know this quick share thing before.
Okay, got it.
I think I have to.
No. Okay, so if Dorothy shares that, and then I'm going to, let's see. I'm going to stop sharing for a moment. So Zoom is not going to see me for a minute. So sorry, Zoom folks, hang on one sec while we get. Okay. Okay. So you should be seeing, you in the room should be seeing my report builder. And nothing is coming through on Zoom because I stopped sharing. So let me go back to my Zoom and share. Share screen. And
We're just seeing the report builder.
okay, so people on Zoom, if you won't be able to see both, unfortunately, but you'll be able to at least watch me, and I'll read the scenario too. How does that sound? Okay. Nope, keep it plugged in because the room here is going to see. Okay. So our scenario, and this one we started with a really in-depth one. Okay, we're trying to tie in our risk methodology talk this morning with how you can leverage some of the risk information in the CDV itself. And so this scenario is having us look at, so in our analyst cafe sessions, and those are webinars you'll all become familiar with each year as we release our new risk models. Our analysts that create these model groups do a presentation about the annual changes, okay? And they always provide you with the most frequently found variables in our risk model. So of all the 900 risk models, what bubbles to the top? And it really gives you all a priority of like, where do we want to focus and prioritize some of our coding and documentation improvement efforts? So malnutrition, the example Dorothy used earlier, generally every year bubbles up to the top. Malnutrition is one that it's in so many of our risk models. It's something that physicians document, but we don't always capture readily in our coding and documentation. And so that's where we can really start to look at opportunities. So we're looking at malnutrition as a highly weighted and frequent variable for both academic medical centers and community hospitals. The scenario wants to know how we can identify the model groups that include this variable in our patient population. So that's going to be step one. And then step two is going to be, how do we create a report to see our frequency in which this variable is being captured for the model groups as POA. So we can look at POA yes and POA no in that model group, okay? Anybody have any questions about the scenario? Okay, so let's step through it. Okay, so we're gonna start with that first section. So this is gonna be a patient outcomes report. Would you guys like me to make it a little larger?
Yeah.
Okay, if I can. There we go. How's that? Better? All right. Okay, and I've set my defaults, so I'm using the 2022 risk model. Vizient by default is still at 2021. When we release our very first baseline Q&A calculator, which is going to be coming out in the next couple of weeks, that's when you'll see the default change over to 2022, just so you're all aware. At any time, you can change your default and set my preferences if you want it to be the 2022, and you can on the fly in the tool always change it to 2022. So I'm using 2022 risk model. I'm going to use the latest ARC version, although for this scenario, we don't need to worry about ARC. And again, we're going to look at patient outcomes, but this time we want to segment out our data by the risk model group. So I have mine alphabetized. Hopefully you guys all do as well. That's something we show in orientation. If anybody needs help with that after, just find us and we're happy to help you. Makes your life a lot easier if your variables are alphabetized. So I'm going to choose by risk model group. Oh, you know what? Because we were talking so long, I was kicked out of the tool. So I have to go back in and yeah.
So which one?
Risk model group mortality.
Right here, where my,
Yeah, I'm signing back in, guys. Sorry, it's a frustrating thing, but again, it's as designed because patient protected health information. If the system sits idle, it's going to log you back out. Okay, so All right, so patient outcomes by risk model group mortality. I believe the time frame had asked us for the most recent 4 quarters. For you all, you want to go back to Q3. We're going to select Q2, Q1, Q4 21. We're going to multi-select those 4 quarters. I've already populated OU Med Center in my focus hospital. Moving down the page, we don't have to worry about any comparators because we're not running this as a comparative report. We're just running this looking at our own information. And then we want to add the diagnoses in, right? So we're looking at, remember back to our scenario, we want to capture that risk variable for malnutrition. So when we go to our advanced restrictions section, remember that's a fly up wheel, just hover over it. Don't click on the purple, just hover and then go to your diagnosis procedure. And we're going to choose any diagnosis. Okay. If you've been in Builder, this should be a familiar screen to you, right? If you've ever used filters for diagnoses. So this might be new though. Under the operator drop-down menu, I'm going to give you a new option to select, and it's called in custom list. When I open that, I'm going to use my search bar to look for malnutrition. And once you hit search under malnutrition, you're going to see a whole bunch of funny things available over here on the left in your custom list. Remember, Vizient always has 2 years of risk methodology in the tool. So you're going to see all your options for 21 and all your options for 22, plus those stratified for community, plus those stratified for AMC, right? So, what we're wanting to look at here is 2022 AMC. And we want to look at the ICD-10 codes for malnutrition. And I'm actually going to look at both POA yes and no. So I'm going to multi-select those.
Forgive me if this is obvious, but since we're doing the past 4 quarters, excluding the current one that takes us into 2021, do we still just use the 2022 list?
Yes.
Great.
Yes. So it's a great question, actually. So our benchmarking report for Vizient, the Q&A, actually crosses 2 years, calendar years. It always runs from July 1 through June 30 of the following year, but we'll always apply a risk model for the previous year. We don't change our risk model in the quality and accountability study until that following year.
So even, I guess, sorry, I just
Mhm.
okay, if we were going to look back, because a lot of times we benchmark ourselves against ourselves, just to, I mean,
Yep.
simultaneously that we're looking at other systems. I guess I should put my mic on soon. So if we wanted to look back, let's say 2, or I guess in this scenario, 3 years, so that we can have our baseline data and compare to current state. Can we use the 22 list, that model, to look at that entire period? Or do I have to go back and select that 2021 now because I've gone outside that 2 years?
Yes. Whatever you're selecting here too, just to be clear, whatever you're selecting here should match the risk model group year that you're using. So the 2 different things essentially. Here you want to make sure it matches whatever you selected in your radio dial. But to your point, in your radio dial, you can always say, I want to look at my 2021 performance in that risk model.
And that's there just for that purpose, for your, for your goals, strategic goals. Sometimes,
yeah,
your goals were like based on 2021 version. Yeah.
Understood. I agree with that.
Yeah. Did you have a question too?
I did. So if you were to select the 2021 and move it over as well, would it affect anything, or it's, I guess,
It would, because those potentially, I guess the best answer is potentially, because the definitions for risk variables in 2021 might have changed. Maybe there's a new code in 2022 that we're now capturing as a risk variable that's going to trigger. So there's no harm in it, but the potential downside of it is that you would potentially be missing a capture of a ICD-10 code that's now in 22 that wasn't in 2021. Make sense?
And also for the service line, that's when you select that, that's the version that the service line is also.
That makes sense.
Mhm. So then functionality I've highlighted and selected. I'm going to use the over arrow to now select those. The way I use any of these windows, here's a tip for you all when you're using CDB. Start at the top and just work your way down this window. And at the bottom is always going to be your save button or your send to CDB. So, you know, kind of these windows can be overwhelming when you see all this information, but just think about it systematically, kind of following top to bottom. So now I've got those selected and I'm going to choose the send to CDB option down at the bottom. So now you see we've got these, you know, we're looking just at malnutrition codes, but we've got our data up at the top in our group by variable, which is how we're going to stratify our data. How we're going to break down our data is going to be by risk model group for mortality. So I'm going to run this in tabular by clicking on that little grid icon, which is the tabular. Again, as a refresher, tabular is always the way in the CDB platform that you can drill in from a report. If you run it in Excel from there, you can't do a drill down, right? You've got just your Excel output. So if you run it in tabular, you can always then send it to Excel if you wanted to do a drill down. All right, so let's talk about what we're seeing here. I'm going to make this one just a little bit smaller. So now remember, we've ordered it by risk model group. So what you're seeing are all the different risk model groups for mortality. In the second column is your case volume. So those are the number of cases that fell into that model group that had malnutrition coded as either yes or no. These are model groups that have during the time frame. Exactly.
And
What-
I'm so sorry.
You're good.
I forgot to ask this question earlier, and I think you may have addressed it, I just wasn't listening. When there's a number in parentheses, what does that represent?
The number in parentheses under your case volume is always your length of stay outliers. So it's in addition to, so for example, in my output of model group 13 adult spinal procedures, there was one case and in parentheses, one outlier. That means that one case was a length of stay outlier. Vizient defines a length of stay outlier is a greater, falls into the greater than 99th percentile for that MSDRG. That's what a length of stay outlier means. You have an option in your standard restrictions fields to eliminate outliers. So kind of back to your GMLOS, I'm just thinking out loud here if that addresses that or not, but you can remove outliers from your analyses too as a standard filter. You can say, I want to take out my LOS outliers.
So then just to build on that, number 23, we have 12 cases, and of those 12 cases, one of them was
an outlier. Yep.
You.
And anytime you see orange font is a drill down. So I can drill down into that one outlier. I can drill into all 12 of those patients.
Right.
Yeah. For the purposes of this exercise, so we're looking at, again, we wanted to see which of our model groups, we're kind of looking for volume here, right? Which of our model groups have malnutrition coded the most, whether POA yes or no. So I'm going to click on this cases column and do a sort. So now I've sorted highest to lowest by volume. And we see that 903 septicemia, 206, 132, and 141 are all kind of bubble to the top, if you will. Like if we wanted to say, let's pick the top 5, those would be the top 5.
More questions?
Yes, I love questions. We love questions.
Remember the number that you shared with us was it 25 number? So would we only consider those top 6 to be like valuable?
Yeah, only when volume only matters when you're looking at index. Volume really only matters for this, the purposes of this exercise. We're looking at counts of cases where malnutrition was or wasn't. So it might be a lower volume, but it's still impactful enough that we can say, yeah, let's make sure we've got malnutrition coded on those patients. So volume is really only applicable when we're talking about index, because it really skews that O to E ratio calculation, if that helps. Yeah. Does that help?
Yes. Okay.
All right, so that was step 1 of our scenario. So if we go back to the scenario, the question asked us, part 2, is this the second report? Yeah. Mm-hmm. So then create a second report to see the frequency in which this variable is being captured for these model groups. Okay, so the first part of the exercise was let's figure out what are model groups that are bubbled to the top. Now we're going to go back in and change this report to say, okay, now we only want to look at those 5. And really what we really might want to consider doing, it's not part of the scenario, but we could consider running a comparative group, right? So for our top 5 model groups where mortality, where malnutrition impacts the mortality expected value, how are we coding and documenting as compared with our peer group? Right?
And in that outcome, are we gonna see that in the comparative group, are we looking to see if their top 5 are the same as our top 5? Like, is that the outcome that I'm gonna see?
No, it's what you're going to see, because we're going to filter the data to say, only show me these top 5, but you're going to look at your POA yes and your POA no versus your compare group.
Understood.
And so if your compare group has a lot more POA yes, they're capturing that as a risk variable to drive their expected. You are not, so you're not getting credit for that.
Yeah, you're coding it, but it's
You're-
no, it's a POA no.
Right.
So maybe you should look at making sure.
So are we capturing that within our initial assessment?
Yeah,
And did it make it to the documentation and coding? Did it make it to the, not only are you capturing in your notes, but did it make it to coding? Which is where your CDI folks are going to come in like too.
Yeah, that's great. Thank you.
Mhm. So I'm going to go back to Builder, and we're going to kind of reset. We're going to do this same exercise to answer part 2. Okay. So this time, just follow along with me. So I'm going to, the way to reset Builder, I always just come back up and hit Builder, hit it, and then everything kind of resets. You lose all your other advanced restrictions if you didn't want to keep them, you know, scrolling down. All right, so this time now, we're going to still choose a patient outcomes. And I don't know if we said this in orientation, but this is one of my favorite statements too as a trainer. Your patient outcomes report is your bread and butter report of the CDB. Okay, that is where you're going to see length of stay, mortality, and I'm going to show you too how we can add a range and pull in other columns. But patient outcomes far and away is the most common report you're going to run in CDB. That and readmissions probably number 2. Okay, so let's do patient outcomes as our type. And then this time, we're going to actually stratify by discharge. Okay, so I'm going to choose, I'm sorry, not discharge, diagnosis. Thanks, Dorothy.
okay, that's fine.
So under my by variable, I'm now going to select diagnosis. Okay. You'll also notice this little checkbox here that says use custom lists. So this is that same idea, that same concept, only this time we're going to use it in our, instead of filtering for it, we're going to actually use it as our segmentation. We're going to break our data out by that. So I'm going to click on this box. I want you guys to kind of click and watch with me what happens. We click that, and then we have a new hyperlink option now that says select custom list. Okay. So we can go in now and choose that. And again, a new dialog window is going to open. I do have to change my screen configuration for this one. Sorry, guys. It's going to be tiny, but you'll see. So now you have some options. The first header is user defined custom list. So if any of you have created some custom lists for diagnoses, you'll see those listed here. And then under that section is the Vizient defined list. And again, these are based on the Vizient definitions for those risk variables. This list is huge. If you use your right scroll bar, you know, it's a lot. So here's a tip. You can use your Control F, F like Frank, Control F. And remember, we're wanting to still look at malnutrition. Whoops. M-A-L-N-U-T. Spell it out loud or I'll misspell it. And my find feature now is going to say, okay, here's everywhere malnutrition. Again, we have to have a keen eye to make sure we're selecting the right thing. There's 8 instances of malnutrition. That's going to include the 21 version, the community version, some PED stuff. So we want to make sure we're choosing the right thing here. My very first option that I see are the 2022 AMC malnutrition. I have POA yes, and I have POA no, and I'm going to select both because I want to see my output stratified by those that are POA yes and those that are POA no.
And these are the ICD codes I showed you earlier with the risk variable definitions. It's just giving you like a grouping of.
They're already like consolidated into that bucket, if you will.
They also you thrive on member feedback. So
Yes.
I think that
Yes,
we would love to see, you know, rather than using control F.
agreed. Yes.
So I'll go ahead and put that on record.
Duly noted.
Do we tell them about UI reflection?
All right. So then so I've selected the 2 of interest. I'm now going to take my scroll bar and I'm going to go all the way to the bottom of this window and save it. Okay, so now I know that those are the 2 that I'm looking at. I can also close out my control find feature using that little X. Okay, again, let's choose our same time frame. So Q3, Q2, Q1, and Q4. We wanted the rolling 4 quarters, most current. Did yours lock up? Oh.
For now.
Oh, it was right across the street from it.
Just one.
It might be your screen configuration.
We're still
Okay.
doing OUS.
Yes. Sorry, Edmund folks, if you're on the line that we're not using Edmund as, as an example, but you can, if you'd like to, you can.
So I guess something worth noting though is we are not only excluding programs in this particular scenario, correct?
Yes, so I have OU as my focus. So OU Med Center with Medicare ID.
Do we have the ability, similar to on the quarters where we selected multiple, to select all 3 of our hospitals simultaneously?
You can do a couple of things, yes.
Oh, wait.
Yeah, I'll show you that. Let me add myself a note for that. And truth be told, everybody, we're probably not going to get through all these scenarios in the time we have allotted. So what we've done is we've given you step by step for every one of these scenarios. So if we don't get to them today in the training, you can, we literally have the step by step to walk through, and then we're also here to support you after we leave today. If you reach out to us if you're running into any troubles with these, but you're bringing up some good examples that I want to show. So there is something called a hospital flag that will allow you to look at your data broken out by hospital flag, because you have that set up, right, Tanil, for children's that not only are they their own facility, but you can look at hospital flag within, or is that? Okay. Okay. Also, there is, if you notice, to answer your question, there is focus hospital system. So if we clicked in that next section, you would see OU system listed. And what that's going to do, OU Med system, that's going to roll everything up into one line item. So that would be all your facilities broken out. Okay. All right. So again, back to our exercise, just to recenter everybody. So this second part is saying, okay, for those top model groups, for those top high volume model groups where malnutrition is impacting for our facility, how are we capturing our POA, yes or no? So we have to do this last step. We have to tell the tool now, I only want to see encounters that fell into those top 5 model groups. And Dorothy is my great scribe. She wrote them down for me because I forgot to write them down. So when we did that first, remember, right? We had to sort, capture them somehow. Yes, yes. So what we're going to do now is go into complications and risk adjustment as a filter.
I think my view looks slightly different here. I'm on standard restrictions, but I don't.
You want to go down to purple, advanced restrictions, sorry.
It looks.
Yes, no worries. When you hover on advanced, you get that little flywheel. Yep, flywheel pop up.
Same we did earlier. I just was.
You're good, you're good.
Yeah, I know.
Hover, right? I'm a click happy too. I've worked here 4 years. I do trainings. I still click. I'm like, why am I clicking? I'm not supposed to click. I'm supposed to hover. Okay. So complications, hover, and then you're going to search over here on the right of complications and look for risk model group mortality. So again, what we're going to tell the tool here is only show me, this is what I love about filters, is only show me encounters that meet this criteria. So now we're going to look for those model groups. And again, this is where I think your search function would be much appreciated, or your hotkey function. Unfortunately, we don't have that here. So let's start with 132, model group 132. So I believe it'll start 00132.
By the way, before it was just the numbers. There are no.
Yes, this was a newly added feature to have the description behind it. Yeah, so that's one. The next one, if we scroll down and use the control click feature, because we're going to multi-select, we're going to look at 141. So adult cirrhosis and alcoholic hepatitis is our second one. And then we'll keep scrolling down. We want to look for model group 206. Which is
using a comma and be able to pull that.
For your search, you could try that something else.
But you have to,
It doesn't, yeah, okay.
No,
and I
did
think you have
figure
to
it
put,
out individually and hit like tabs selected, and you can tabs them for
Yeah.
you, so you don't have to pull down like, it's just doing a running list.
Mhm.
I think it's searching.
Okay,
So we did 132, 141, 206, right?
yep.
yeah. then
And now we're gonna go to
218.
218, which is adult renal failure. And then actually the highest volume, which I see kind of across the board when we do this exercise, is sepsis, model group 903. So we'll scroll all the way down to 903 for sepsis.
Danielle, can you try this, make it like 4 digits or 5 digits, 00218? Okay. That's how it's showing.
Yeah, I was doing, if I could see your serial.
Nope, that didn't work. No.
Okay. So now I have those top 5. I'm gonna, and again, we could save this as a custom list. I mean, if we, for whatever reason, we could always name this a custom list if we wanted. I'm not going to, I'm gonna say, okay. And now it's populated those risk model groups in my advanced restrictions. So now I'm filtering the data set to say, only show me encounters that fell into those 5 model groups. Everybody with me, ready for me to run tabular? Okay, I'm gonna run it. I always wish there was like some music that played, like Jeopardy music or something.
It's the first music that went into my head when you started saying
Yeah.
it.
I shouldn't have any diagnosis. I just one.
Yeah, I think that was when we reset, for whatever reason, your advanced restrictions didn't go away. You can delete that. You can use the trash can. Yep, perfect. So, so this might happen from time to time so you'll see, I ran that report. I clicked tabular and you're like, where's my output? Like, where did it go? Sometimes you just have to hover over your browser and you'll find it buried. It opens in not always a new window, because you'll see my windows up here, but it's kind of down here in this little browser icon, and that's where I'm going to find my output.
Oh, it might be blocked. So you go up to your search bar, there's a little thing that looks like an Excel document with a red X on it. Just go and select always allow pop-ups from Vizient, and it will let you pull it.
Yeah.
Yeah, for whatever reason, it didn't do the first time, but this full row.
Pop-up blockers. Yeah. If you've ever cleared your cache, or if you're in a different VPN, maybe if you're logging in here for the first time, the web browser is not picking up that you've got accept pop-up blockers from Vizient. So you're being blocked from new windows opening from Vizient. All right, so let's look at this a little closer here. So now what we're finding here, let's talk about what we're seeing. So again, we used at the top, we broke it down by POA yes and POA no for our risk variable malnutrition. Remember, a risk variable has multiple codes, but we're just looking at that variable itself. There were 225 cases for those 5 risk models that were capturing it as yes, and only 2 as no. So really, we're doing a good job, right? Like if you look at that, that's 0.001%, 01%. I'm not good at math. We can also look over at the expected column, right? So, what was our expected mortality in those patients? Now, again, we wouldn't want to look at index necessarily. In this case, we had 0 deaths, so it wouldn't really skew our index. But if there had been 1 death, that index value would not be of interest to us. But we can certainly look at that expected value and say for those, for those patients, we're potentially we could drive that up even further if they were truly POA. Yes, right. That's the other thing. The dangerous territory that Vizient gets into when we're talking about coding and documentation opportunities, it's within coding guidelines, right? If there truly was not present on admission, but what we see is there are many opportunities where indeed in the prog notes and other things that we see, there is indication that could have been coded as present on admission and it wasn't. Okay, so that's really our intent, is to help you capture that and look for opportunities to best capture that. So that it might require a chart review, right? These two cases, you could say, let's go into those charts. Let's look at the notes. Let's look at notes. Was there an opportunity missed that it should have been present on admission? Does that make sense?
I guess it's also Robert, this team. Like, hey, write it this way.
Mhm.
So I think that some of our, there is just not getting docs as well, and because of what we have to.
Thank you.
All right. Any questions on this one? We started off with a doozy. This was a
That's why they put it as their number one.
Yeah. Yeah. We had Bobby and Sunil kind of rank what scenarios should we cover first. And
Yeah, this was great.
okay. So I already looked at the time. We're already like almost at 2:15 and we just got through one scenario. So I want to show you guys one thing. So it was about the add, arrange, remove columns feature. Remember that? So I'm going to keep this report as is. I'm going to run this the same, again, just for the purposes of showing you what that add, arrange, remove function looks like. Okay. So again, it only is available when you're running it in tabular. So using the grid icon in tabular, you'll see this section that says customize your report and this orange hyperlink right here that I'm circling, add, remove, arrange columns. Okay. When you click on that, you're going to get a new window box open. On the left side shows you all the additional available columns you can add to your report that aren't currently in there. On the right-hand side is all the columns that are currently in your report. You can manipulate, you can highlight. So there's your geometric mean length of stay observed. I can highlight that and I can add that to my report. And it's going to actually show up down at the bottom of the list. I could move that up. I could highlight it and click the up. This is the order it's going to appear in my report output. I want it to appear next to my other length of stay information. So I'm going to use that move up feature and bring it up by my length of stay info. So again, not required, just showing you the functionality of how you can, move these around. But so I'm going to say, okay. And now if you look at my report output, now I've got the geometric mean length of stay in addition to the other data elements.
Okay. I think that there may have just been a misunderstanding earlier. The concern that I had is that I thought that you were telling me that the mean length of stay was going to report out as a whole number, but it's coming as a fractional number. So I don't think it's that my concern earlier.
Because it's an average, right? So on a individual patient record, you're going to see a singular whole number. On a patient record, you'll see a singular whole number. So yeah, maybe we misinterpreted the question too, but we take the mean of the population to calculate that. Okay.
So
Okay.
Still a sort of a valid concern, but at the very least, looking at this, there's still a lot more specificity than what exists.
Okay, good. And again,
just to make sure I understand correctly.
Yeah.
Now that we added that in, so your third, I guess both of our third column is the mean length of stay observed. So for the POA, yes, but that group, we're saying that the mean, our patient population was 9.68.
yes,
And the geometric mean was 6.35.
yes.
Okay. Thank you.
Yes. Yeah, we didn't pull any comparators in here, but we could certainly have pulled comparators in and looked at all these data elements in a comparative fashion too.
I appreciate it.
Yeah. And again, pulling in the geometric mean for this exercise, it was really more to show you the functionality. I don't know that we would stratify a, POA yes, no in the geometric mean length of stay stuff.
Right.
It was just more to, yeah.
I just want to make sure.
Yeah.
I understood.
Yeah.
Awesome.
Yeah. So the other thing we use this add, arrange, remove columns for is your direct cost. So when I talked about patient outcomes being bread and butter and you see those outcomes, by standard default, it's mortality and length of stay information, some complication information, some ICU, but you don't see cost. If you want to pull cost in, you have to use that add, arrange, remove feature. And then you'll see when I do that, there's the ability to look at the mean direct cost observed, the mean direct cost expected, and then that direct cost index. And I can move those over, add them to report. This time I'm just gonna leave them at the bottom of my list and you'll see what that looks like in the output. I'm gonna select OK. And now in my output, you'll see, because I didn't change the column location, those are all added to the back end of my report. So after case mix index, you'll see those 3 additional values I added. Okay. Whenever you add, arrange, and remove columns, you also have the option to save this layout. So you don't have to go in every time and add, arrange, and remove columns. You can say, I want to use this all the time. I'm going to save this, and you can name it a layout. Okay, I'm going to just call this, I'm going to say OU test and save.
Did you, yes, you did. So data looks interesting. Some of our data came, like yours and mine aren't the same. Did you do mean direct? No, you did total. That's fine.
Oh yeah, I meant to
So-
choose direct. I was hasty.
No worries.
So
No,
yeah,
it's totally fine. Regardless, you'll see this on your percent deaths observed. And then I'm also seeing it on mean direct costs where it's got the 2 extras, but I haven't seen anywhere in the
Yep.
qualifying.
I'll show you where that is. Well, hold that thought. Let me go and just show you. So I saved that layout. I used save layout. Called it OU test. I can now also set this as my default layout. So if I want OU test every time to be all those other columns I pulled in, I'll save that as my default. And then when it opens, it can do that. And you can always go back to the Vizient default. That's still an option there for you too. Okay, to answer your question about the asterisks, up here under report notes, anytime you have a report output where there's report notes, if you open that header, it's going to give you all the footnotes associated with this report. And so an asterisk denotes a significant difference between the observed and expected values at the 0.05 significance level. And 2 asterisks is at the 0.01 significance level. So it gives you all of those footnotes.
So that's something that you can drill into too, because the difference. More asterisks.
So I know we're due for a break now based on our agenda. Again, I know we only got through that one scenario. What are you guys' thoughts? We probably need to stretch a little bit, maybe do 1 or 2 more scenarios and then move into resource manager, or what are you thinking? Okay. Is the group okay with that? Again, the scenarios we gave you very specific step-by-step. So we would highly encourage you to go through those scenarios, you know, potentially even this afternoon, and we can revisit anything tomorrow you have questions on, or you can always reach out to us after we've left on site and help you with those as well. Let me look at the scenario. So we show you how to run something stratified by the different service lines, by sub-service lines. Scenario 3, if you want to click over to that one, is looking at some patient safety indicators. So we show you how to segment your reports out by patient safety. And then I think some ED type scenarios where we can stratify our ED. So patients that came in through the ED versus those that didn't. Pulling in some lab data. So now that you have lab data available. So a real world example is our sepsis population, right? Were we able to get a sepsis lactate within X number of hours with a value? Like we can run reports like that. So that's what all those different scenarios are set up with for you guys.
So where's the step by step?
Oh, are they not in there? I think
Oh, you just have the scenarios.
we'll send the step-by-step out. We'll send it out.
Because
Yep.
we want you to click.
Yeah.
We didn't want you to get you the cheat sheet.
That's right. That's right. That's right.
I'm kidding.
I need to teach you. Yeah. And we love the dialogue and questions. So it's balancing, right? We didn't get through every scenario, but I feel like there was maybe tips and hints that we got spread in there for you guys. So let's take a stretch break. I think maybe we can figure out maybe 2 or 3 more to go through. I don't want to infringe on your resource
No.
manager time, and maybe do number 2. Okay. All right. Perfect. Bobby wants to prioritize number 2. We'll do that when we come back. So I think let's be back here at 2:30, like 8 minutes. It's not a huge amount of time, but at least time to stretch. Okay.
I never got to the screen. This is what here with water. Everybody else around me had. Sorry. I put these. Mhm. And then I clicked on that, nothing came up. Everybody else can
Oh,
do something.
operator, you click on the
Yeah.
arrow there, let's try it. Yeah,
Okay.
I
So,
can go to where you are.
figure out where I was.
It's at the bottom.
Go back. And I went
Second one.
in the diagram.
Let's click on the operator.
Right here,
The arrow.
it was blank.
Where's his blank? Maybe she doesn't have. Show. That shouldn't be there.
And I did all your levels.
What is
So
the,
you did
what
that,
risk
you
model
did that
is?
before you were.
No, I mean, I did all your education
Oh,
stuff. And I supposedly have the same access as everybody else.
it shouldn't be access dependent.
So that's as far as I got.
You're right.
Yeah.
Got nowhere.
Actually, so many things like- no, that's right. Okay. We'll see, so many things look different there.
I can't read the wording back there, so I'm like, I can't follow.
That's very
Can't see it. I'm blind.
I'm so sorry. I can make it bigger.
Yeah, I was thinking, can we take that off or does it have the scenario part?
We're gonna send it out to you guys. We're gonna send those out.
Okay, yeah, I just can't.
I'm like, I'm so sorry.
On that one,
I'm so sorry.
So just take it out.
So your screen.
Yeah. Yeah. Or no. I think we'll leave it up, but we'll just make them both bigger. You can like blow yours up. Hey, I don't know what's happening there. Do you mind if I take it? If you stop, okay. I wanna see what other, there's no custom list. Oh, okay. So, and that way it'll show you. We had that. I think that's, so of the 7 we wanted to get through, we are going to cover scenario 2 now. So at least we'll get through 2 with you live. And then again, we're going to share the step-by-step how to walk through the others. So for this scenario, what we want to look at here is we're going to run a report for our general medicine subservice lines. And I don't think we talked about that yet this morning. We talked about, or this afternoon, we talked about service lines. Within each of those Vizient defined service lines, we also break those down into subservice lines, not for every single service line, but obviously like Gen Med is a huge bucket, right? We can separate Gen Med out into gastro. We can separate it out into, I think there's even a subservice line for HIV. There's so different granular ways of looking at your Gen Med population. So this exercise in scenario 2 is having us look at our report broken down by your subservice lines. And again, another useful tip when you think about report builder and using the CDB, in that top section, anytime you choose a by variable, that's basically just how you're going to break your data down and look at it visually in those different categories. In the bottom, in the filters, is how you're going to limit your pull to say, I only want to look at patients meeting this criteria. So the top section, think about your report output being, broken down into line items, right? All the different line items, but your bottom section is, I only want to look at encounters meeting X, Y, Z. Does that make sense? Okay, so we're going to run a report looking at our subservice lines by discharge month for a calendar year that shows the mortality and the length of stay indices, easy for me to say. So remember, anytime you want to look at mortality or length of stay, think patient outcomes report. Those are your reports where you want to look at those index values. Then the question is asking us to identify what subservice line shows our greatest area of opportunity in mortality, and then how does that subservice line group's mortality compare with a cohort group. So we're going to build in a comparator into this one. So let me get out of the scenario slide, and I'm going to go into bear with me one sec. Okay, I'm going to go back into report builder. Okay, so you should be seeing my report builder up there. Again, for this scenario, so we're wanting to look at a patient outcomes report because it's asking us to find mortality and length of stay information. So we're going to do patient outcomes, but this time we're going to segment it out by that Vizient subservice line. So when I open my variables, my ways to segment my report, I'm going to look for V for Vizient, and you'll see subservice line is an option. So I'm going to select Vizient subservice line. But the report also wanted to see it broken out by discharge month, right? So I can use this multiple group by hyperlink here. So I can choose up to 3 ways to stratify or segment out my data. So I'm going to choose the multiple group by option, and I'm going to also select discharge month. The functionality here is we highlight, we click add, so now it's selected, and then over here to save. So now we're going to look at it broken down by those 2 variables. Then we want to look at our time frame. Again, what was it? Let's just look at 1 quarter of data. Let's look at Q1 2022. And again, in this first part, we're not using a comparator. We're just wanting to look at our own data. So I'm going to skip over the comparison section. And then down here in our filters, we want to look at only the general medicine service line. Okay, we want to break it down by Vizient subservice lines, but remember, we only want to look at the general medicine subservice line. So now we want to say, how can we limit our pull? So under add restrictions, we're going to go under clinical category. That's where you'll find all the Vizient service and subservice line information. I'm going to highlight and select subservice line. Oops, I'm sorry. That was incorrect. Yes. I'm going to select service line, forgive me. Again, service line being the hierarchy, the higher bucket. So we're going to look at just general medicine. So now what this report is going to show us is all the subservice lines that live within general medicine. I'm going to say okay. And then I'm going to run it in tabular. Okay, let me blow up my visual here so you all can see along with me. So now what we've got broken down is the Vizient subservice line by discharge month. Remember, I only chose 1 quarter of data, but you'll see that breakdown now of discharge month of January, February, March. We have our other, which is kind of a generic, like other category for our subservice line for Gen Med. We have Gen Med blood disorders, Gen Med COVID, Gen Med circulatory, etc. Okay. We can look for where our highest opportunity is by looking at our mortality index. Now, this is going to get a little interesting because you can sort any one of these columns, right? We can look at our index, and this is where Dorothy's risk methodology information comes into play too, because we have different case volumes here, right? So we can pull the report, we can actually sort those columns by the index. Okay, highest to lowest. So now this represents our highest index. But because we've got the months in there, that is going to kind of make it just, you know, a little bit, we're just going to have to use our analytical brains a little bit here, right? So we've got, okay, looks like the highest opportunity, an index of 10. Remember, we want to be below 1, an index of 10. But this was only 20 cases. So maybe that's not the best. Let's kind of keep moving down then. Let's look at, here's an example, 64 cases. So let's, and again, I've got my screen configured so everybody can see, so I have to scroll a little bit. So gastroenterology, we had 64 cases, so a decent enough volume there. And we can look at our index for mortality, which was 3.86. Also opportunity, right? Are your numbers a little different? Do you have 2022 selected for your risk model?
I think mine was defaulted to 21.
Yep. So if it's defaulted to 21, that just shows you how the risk model matters. It can change from year to year. So, yep. Good mistake. Great learning mistake. Exactly. And that's, again, that comes down to data governance principles and what you all want to use as your risk model for your report out with, you know, when you're socializing the data with others. You know, when are we going to make the cutover, right? Like answer those kinds of questions as part of your process.
Or you can also sort by percent deaths observed. That's your mortality rate.
True.
For those smaller cases.
Yeah. For smaller cases, you could look purely at a rate. When we move into that comparative piece, though, that's where it goes back to our very fundamental premise of if you're comparing against another hospital, looking at rate really doesn't take into account your risk adjustment at all. So anyway, we could also look by case volume. You know, I could sort case volume and say, well, what is my highest case volume in my sub-service lines for gen medicine? And where are my indices? Here's an index of 2 with a volume of 68. That's also gastroenterology. Again, we have this extra layer in here of discharge month. That's why we see gastroenterology. It looks to me like that's where there's some opportunity. Your sub-service line for gastro. Again, these are patient encounters that fell into gastro service line. So it doesn't, it's in many cases, it's probably indicative of your gastro service, but there could be, for whatever reason, patients falling into here that, you know, might, trying to think of a clinical.
Primary diagnosis, correct?
Correct, a DRG.
So
DRG.
I think everyone in the room is probably aware of this, but one of the things that I hope you can see that people are, is this idea of time. So this is definitely going to be in flux for a while because there's a lot of going back and forth on determining should we have a team, a physician team that's just accepting them officially and transferring them to another service. So that's a significant conversation that's going on right now. But it's very likely that we're going to see this continue to be in flux for a while if you're working on data for OUPC specifically. And Edmund is probably, as they're in the conversation about it will start affecting and raising it as well.
And again, traditionally, again, I'm going to make some generalizations, but you know, gastro is a service line you might not expect to see a lot of mortalities in, perhaps, right? Yes, if it's a colon CA advanced, we're finding it now, they're probably going to fall into oncology, right? These are pure gastroenterology diagnoses in that service line. So maybe a GI bleed that we didn't expect to die that died, or you know what I'm saying? So it kind of broadens your thinking about how you're classifying these patients too. But in general, just like ortho, you know, you wouldn't expect to see ortho patients expire, especially in elective cases. So, you know, kind of orient yourself that way too with some of the mortality stuff. So, okay, so for the sake of time, so we did that first part. Now let's build a comparator in. So let's look at gastroenterology as a subservice line. Let's say we've done this analysis and we really think based on the volume and based on that index, gastro subservice line is what we want to focus on here. So I'm going to reset our builder. I'm going to come back up to the top. I'm going to click on report builder because I want to wipe everything else out. Yep, just close the X. Sorry, to close any report, you just click the X in the top right. That closes it. We're going to reset builder. Again, I've got my default set for 22 risk model, etc. So now this time we're going to create a compare group. So now we want to compare, okay, so we've identified our facility has an opportunity in gastro. how do we look against others, right? That's another really important context, right? Especially when you start to see improvements and say you have a O to E index for mortality less than 1 and you're like, rocking it, we're doing awesome, we're 0.9, but you run your cohort aggregate and they're at 0.6. That's still technically an opportunity for you all, right? So it's almost like you have to take that next layer of analysis and say, you know, how do we look compared with other hospitals that are like ours? So in this one, we're also going to do patient outcomes. This time we're going to do by hospital system. We're not going to, we know what we want to look at here. We've identified gastro. Let's go back to our time period and keep me honest here. I looked at Q1, correct? Q1 2022. We don't need to break it out by discharge month in this. Okay, and then our focus hospital, of course, is ours. And then this is where the fun part gets, you know, we can go into our compare groups. And I know we trained this in orientation, but this is really the robust part of CDB for you all. You have so many different options here for your compare groups. What I'm going to do is I'm going to actually go into hospital profiler. So forgive me, my screen configuration, you're kind of seeing my other icons there, but it's this hyperlink. It says, help me decide using hospital profiler. And I'm going to go in and select that. And again, this should look familiar. Oh, let me hide this guy here. Meeting control screen. Okay. This should also look familiar to you if you've ever used hospital profiler, but you'll see it gives you a couple different options of looking at some already created compare groups that are already available to you. In this very first option up here called Profile General, up in the top section here that I have highlighted, pre-selected compare groups. It's so obscure and so hidden, it's that I always want to call it out, but you can use that drop-down menu, and that's where you have all these already pre-built custom groups that you can compare yourself against. So let's go ahead and look at the Vizient Quality and Accountability Comprehensive Academic Medical Centers, or CAMCs. That's what you're likely going to fall into for your benchmarking for your quality and accountability study. So we can select that. 2022 is what I selected. Yes. Sorry if I went too quick there. And so let me make this a little bit smaller. So now what that's done is that whittled that list of all the hospitals in the CDB to just those 107 or so that fall into that bucket. Think of Hospital Profiler this way. Hospital Profiler is a lookup table. All you're doing when you open this up is you are looking, it's like a lookup table, a shopping cart, if you like, you know, shopping online, and you're selecting, okay, these are the hospitals I want to choose, but you still have to use this function, send hospital list to CDB RM, okay? It's not going to select all those for you till you choose that last function. So you have everything checkmarked that you want to include, and I'm going to send that list back over. Okay. For whatever reason, highlighted all of my hospitals. It should have only highlighted the AMCs. I'm going to do that one more time. I'm going to look at Vizient Comprehensive 2022. And I'm going to send that list to CDB. There we go. So now I'm back in Report Builder. And if you look at my screen, you'll see these boxes that are these hospitals that are highlighted in the gray are those that I chose from that hospital profiler lookup table and sent back over to my builder. The other really important thing, if you're not routinely running comparative reports, this little show grouped at the very top where my arrow is here is going to be your best friend. Okay, when you are running a compare group, right here where my little mouse is, if you're running a compare group and you have 100 different hospitals, if you don't check show grouped, your output is going to have a line item for every single hospital, which you may want. I'm not saying that's wrong. Just know that that's going to, you know, take a longer time to run. It's just going to give you more data than you might be looking at. If you want to look at it consolidated, you're going to click show grouped. And what's going to be now a line item is for the compare group, the aggregate of those hospitals' performance, if that makes sense. So click show grouped. Yep. And that will aggregate everything. It's really obscure and hidden. And once you're kind of used to using the compare, you'll start to, oh yeah, I got to do show grouped. And I still do it. Again, another example of something 4 years using the tool and I still do it. So, so now, but remember, back to the original part of this scenario, the whole reason that got us started is we want to know our gastroenterology subservice line performance compared with our cohort. So we've chosen a compare group, but let's filter down the restrictions to only pull encounters from our hospital and all the other hospitals I'm comparing to for that subservice line category. So I'm going to go into clinical category, and this time I'm going to choose subservice line. And then I want to find gastroenterology. It'll be under general medicine, which is the larger service line bucket, and then the subservice line of gastro. And I'm going to select OK. So now I'm telling the tool only show me gastro subservice line. And I'm going to run it in tabular. And it does take a little longer when there's a compare group, just because you're mining data from all the facilities. But now we can actually look in a comparative fashion of our performance versus others. And again, this is where you see that comparison line item. Because I showed group, it's all aggregated in one. If I had not checked show group, you'd see every single one of those compare hospitals listed out here.
On comparison, looks like ours is not a hyperlink to drill down. Is that protected?
Protected, correct. As a Vizient employee, I have access to all hospitals because I can troubleshoot, help people, find answers to their questions. So you will not ever be able to drill in, nor will anybody be able to drill into your patient level data. Yeah. Except for Vizient staff. Okay, so what was the ultimate question, right? What was our mortality? How did we look in comparison with our compare group? And so again, let's look at our mortality index column right here. So mortality index, ours is a 1.80 compared with 0.9. So about twice as much in the index value as the compare group. But let's look at a couple other things, because remember what drives index, your observed and your expected. So we can look at those two columns and really get some more information too. Yes, we do have a bit higher observed. So again, observed may be things like clinical processes. It may be things like accepting transfers in, right patient, right place, right time kind of stuff. And then we can also look at that expected column, which again, here it's showing you are actually capturing the expected a little higher than your cohort. So in this case, this is probably more of an opportunity around that driving down observed than it is driving up expected. But we could even get a little more granular with that because there may be pockets. What I found with members is there's maybe even sometimes pockets that you can drive that expected up even a little farther. But and that's, getting really in the weeds. The point of training isn't to get super analytical. It's just more to show you the functionality. But any questions at all about how we got here? Hopefully this was a relevant example to you to really, again, understand that Vizient has service lines. We also have sub-service lines, so you can get even more granular within a service line like Gen Med that has multiple more patient populations to investigate, and then building in that comparison view as well.
You may have questions later, but getting in the weeds.
Yeah, absolutely. And that's, if we need to do another session like this virtually and just really do some scenarios, we have that option we can do down the road too. So, yeah.
And then everyone knows how to share now, so
Yes.
they can always share the reports. And
I guess I know we're trying to stay a bit.
Yeah.
You were mentioning, the opportunity and the observer versus the opportunity.
Mhm.
Can you give me a little bit more context as to why we would be trying to drive up the expected?
Because that's your documentation. So expected is your present on admission factors that would drive your value to be that we would expect patients to have a higher length of stay or expect patients to have a higher chance of dying in the hospital setting.
So if our expected has been significantly lower than the comparison group, that might suggest.
Correct. The fact that it's higher leans us towards no, but again, not to get too in the weeds, but you could even get more granular than subservice line, and you could look by specific diagnoses. You could look by provider and see like who's maybe missing some opportunity that we could even drive that up more if that exists, that opportunity exists. Mm-hmm. All right, so we're totally gonna switch gears again. So you want me to share slides still and you're gonna go to your deck? We never did the deck switch.
Oh, it's okay.
Yeah, that's okay. Okay. So Dorothy is gonna kick us off now with resource manager. Which, has anyone in the room attended our virtual resource manager training? Okay.
You're right.
Okay. So resource manager, well, I'm queuing it up, Dorothy, I'll just talk. This is our way of really being able to look at resource utilization in a comparative fashion within the database. Because in addition to getting all that coding and documentation information, we also collect a file called your line item detail file, which is your patient charges. So what you charged for in the hospital in those major areas of pharmacy, radiology, lab, radiopharmaceuticals, cardiovascular. And so you can take your utilization of those based on how you charge for them and compare that with other hospitals based on how they charged for it. We don't get your costing information. We're comparing it from a utilization standpoint. So number of tests, and Dorothy's going to drive you into all of that. So this is a really different and exciting way to use the tool when you're really wanting to look at quality and cost kind of through that same lens. Why did that not?
Oh, there you go.
Here we go. Okay, sorry guys.
All right. So actually, resource manager, this is not part of the topic that you wanted to add on, but then I figured when you gave me the list of the KPIs and you're very focused on quality and accountability scorecard, and we have metrics in the Q&A that uses resource manager, and Jen will be talking about that tomorrow. So I figured this would be a good one to cover today. So this is what just a short overview of resource manager, and then how you can run reports in Report Builder as well as the Vizient generated reports in Report Express. And then hopefully we'll have time to at least 1 or 2 scenarios. Again, and so so before we talk about resource manager, we want to talk about cost. The one that we were, when we added the additional columns, the direct cost, which is also a risk-adjusted metric. When we talk about costs, we're typically talking about direct costs, and direct costs are those costs related to your. It's related to your patient numbers. So the more patients you treated, the more services you rendered, your direct costs will go up or down. So indirect cost is like your fixed cost that it won't vary with the number of patients that you've treated or patients seen or the services rendered. So it's just natural costs that you incurred by having a hospital, like hospital beds and operating rooms or MRI suites. And costs vary from hospital to hospital, so it's impossible to perform fair benchmarking. So another thing is we can't share your billing information. So this is kind of like for legal reasons. So for cost benchmarking, what we do is we assign your different cost into different cost buckets to perform benchmarking. And the way we do that is we look at your revenue codes and we map that to your 34 different cost centers. And then we'll look at your cost to charge ratios, leveraging your Medicare cost report, MCR. And then we standardize that, and that's standard across all hospitals, so we can benchmark. So that's what we use for cost. And there is actually a crosswalk in our learning center that maps the different revenue codes to the different buckets of services that we have. We also have a CDB 101 on cost methodology if you really want to drill into that. But it's not going to exactly align with your Medicare costs. It's because we do the mapping of your revenue costs to the different service groups. And what you see in Resource Manager will not be the same as the cost of your hospital accounting system. Okay, so it will be a normalized number.
So when your CFO and your financial people see any of the Vizient data around cost, remind them that this is a normalized view. It is not representative of actual cost. That happens quite a bit. But again, because of a comparative database, we want to be able to compare. So this is the methodology for normalizing that cost.
And that's risk adjusted. So the patient outcomes report that Jen showed, and we added the direct cost, that's what we're talking about in the CDB. However, in Resource Manager, it's a little different. When you see dollar amounts in Resource Manager, it will not be related to the direct or indirect costs that we saw earlier. It will be a different methodology, and that Resource Manager again will not be your actual cost. It's just your normalized number, so you can benchmark. And then many times the dollar amount that you'll see will not be associated. You'll not see dollar amounts except for the pharmacy category, and I'll show you later. And it's based on the defined daily dose. All right, so let's start putting the information into context. And this is kind of like the teaser slide that we start with, so you can understand Resource Manager better. So this is a patient outcomes report. And then we added again the hidden fields, just like Jen did earlier, the direct costs on the right. So looking at the focus hospital or demo hospital, you can see that clinically their length of stay index is less than 1, the same with mortality index, less than 1. So quality-wise, they're great, right? So quality department, we're good. We're doing extremely well, even though we didn't compare with a comparison. But when you, but look at your mean direct cost. Your direct cost index is 2.04, so twice that of your comparison group. And even if we don't use the comparison group, you can tell that something is going on because the index is very high. So we want that index, direct cost index, to be 1 or below. So that could potentially is an opportunity for your resource utilization. And what you can do then, you can do the summary of costs instead of patient outcomes by service group to get a breakdown of where your direct cost index is, the higher direct cost. So once you do that, then you would know to go into resource utilization to drill into again, okay? So this is what Resource Manager looks like within the CDB. So again, this is like a very popular slide because they want to drill into that. This is a seamless bridge from one place to another, which is clinical database to Resource Manager. On one side, you have your patient level data and your risk adjusted outcomes in data with the goal of improving your performance improvement or quality improvement. On the other side, you'll be able to enhance the data that you have from the CDB by looking at your Resource Manager data. Specifically, we're using this time the line item charge detail that we map into 8 clinical categories. And the goal really for Resource Manager is just finding clinical variation by identifying trends and patterns.
Quick question, going back to the beginning, and I apologize, but based on the way that we're sending the data packages, our data is always going to be, I guess, a month behind that period. Just want to make sure, just because some of this relates directly to some ongoing work.
Yeah, because you want to make sure that your coding is complete. You know how like by the 30th you won't get the mortality yet all documented by coding and billing, because they're waiting for if they have a CDI inquiry, they're waiting for the doctor to answer first, and then so we're waiting for that coding complete.
Something to mention that for us right now, July is complete. So we have other data that's loaded in, but it's going to change as we submit more of our files each month.
Yeah.
Ties back on to the coding of like 2 weeks.
So we have data, back data, gold one.
Fourth quarter 2018.
The fourth quarter 2018 to July of this year.
Right. Yeah. There is data. Well, there is data in there for August. Like we were saying in the beginning, where there's 3 months submitted at a time. So what was submitted on November 7th was July, August, September. So December 7th, we will submit August, September, October.
So July will not resubmit again. That's why we consider it to be closed.
Good. So I am looking at data right now. It's not-
I haven't, so we submitted September, but there's not a whole lot that actually came through. There's more in August that came through.
So we'll
So
see
you can
data,
see-
it's just, it's going to continue changing until that 3 months.
Exactly.
And not all hospitals submit their RM data. That's an option. Because before, historically, we're just doing, it's a separate subscription, but now it includes with your CDB membership.
And we're seeing more and more hospitals submit it because, to Dorothy's point earlier, a lot of our Q&A metrics, or not a lot, but there are several Q&A metrics that tie in a quality measure to resource manager. So we look at patients who received insulin after having a hypoglycemic incident, look tying again quality metrics into tracking some of your line item charges and being able. So that's why we're really encouraging hospitals to do more of this data submission, because we have those metrics in our benchmarking reports.
And this is just telling you that the data feed is the same as what you're sending to the CDB. But then again, like you said, you did not submit RM data first, so now you're tracking, right? And so we look at over 4,500 clinical resources. So that's an individual line item that we map it to this 8 standard categories that you see here. And the data fields that we use to leverage for mapping these codes, we use the CPT HCPCS codes and the charge codes and revenue codes. So like for pharmaceuticals, we use the combination of those 3 codes, 3 or 4 codes that I mentioned. And then the others, they're just using just the CPT and HCPCS codes. And then for accommodations, we only use revenue codes for that. And this is the way that we benchmark. So, and then you'll be able to see the mapping using our resource manager lexicon. And this is the one that I've been, available in our learning center. And here's a screenshot of that. So for every resource category on the left, you'll see the mapping of the individual resources next to it, and then individual resource codes. And then we provide more granularity using the major category, and then more granular again using minor category, and then sub-minor, and then individual resources. So there are different major buckets, major and sub buckets. And that high impact column, that only pertains to the pharmacy drugs. And I'll show you that in a moment, or discuss that. And then again, you can utilize this to find the individual resources that you want to create your report on. You can also filter. And then for the next one, Jen, this is how you're gonna see it in the CDB. So over here on the right is how you will go to your advanced restrictions and then clinical resource category. Then when you click on that where pharmacy is, you'll see the 8 buckets. So this one is filtered into pharmacy. So there's a major classes, minor classes next to it, and then sub-minor classes, and then the individual resource. And this example right here, we're using the major class of anti-infectives, and then antibiotics, and then aminoglycosides. And then the bottom part there are all the individual resource or individual drugs. And then the unique methodologies to resource manager. So this table, what it's telling you is that with a dollar amount that you see on our direct cost, that's not what you see here. So as you can see, we're only doing that for our pharmacy category, the second to the last one there. That's the only one with a dollar amount. But we're using the defined daily dose that's from World Health Organization for their ambulatory payment classification weights. So again, this is a proxy to, so we'll be able to benchmark with other organizations. And then with the other resource categories, as you can see, we use intensity weight or resource intensity weight from CMS. And then accommodations, there's an NA there because we're just using the revenue codes. Okay. So let's define resource intensity weight a little further. resource intensity metrics in the CDB are kind of like a quick way of indicating more or less expensive services or resources. And the reason that you need to do this is because units are not necessarily reliable measures for costs, right? Different services may use various resources. One service might inherently be more expensive than the other. So the way we do that is by using resource intensity weight, again, a CMS metric. And every line item detail has its resource intensity weight, regardless of where you are. So any hospital will have their own, it will be the same for all hospitals, is what I'm trying to say, for the resource intensity weight. So this is an example. We are looking at two common colon cancer screenings. One is guaiac test, and one is immunochemical, which is FIT test. And as you can see, the occult blood test, the guaiac test, has a resource intensity of 0.05 versus the FIT test, which is almost 4 times, so 0.19. So, but overall, RM is not dictating which test that you should use, but will provide you with the most cost-efficient ways to select your resources. So the next slide, again, just giving you an idea how it will look like with your cost savings. So hospital 1, as you can see on the left, if we were to look at the sheer number of tests, you can see that the hospital 1 looks like they're using just half or a lot fewer resources of the other hospitals, right? But then if we normalize that and use the resource intensity weight on the right, you can see that hospital 1, their usage of the colon cancer screenings are kind of the same as the others. And this is because this is the benchmarkable measure across institutions, because that's how we standardize for each test. Again, this is something that you might want to highlight for the ordering physicians. If they're ordering more of that FIT test, that's more resource intensive, that's something that's an opportunity for you if guaiac test will also give you the information you want. So now we're going to talk about the pharmacy category. So in general, all the drugs are mapped to the different buckets. So in addition to that, we have what we call high impact drugs. And high impact drugs we define as extremely expensive, highly utilized, or they have a high physician preference. And again, those are the only drugs that will have a dollar amount associated with it, just so you can track utilization. And then this is the defined daily dose that we use from the World Health Organization. And DDD is defined as assumed average maintenance dose per day for a drug use for its most common indication for adults in acute care settings. So what we do, we put it in to the next level by adding adjustments such as the route of administration, so oral versus IV, and then the cost for age groups. We make adjustments to that. So as you can see for vancomycin, you can see the route of administration, oral and injection, and then the daily dosage quantity, and then the measure, and then the adult price per day per the DDD from World Health Organization. And then we added the adjustments for age for 0 to 2, and then age for 3.17, which are percentages of the adult dose. Okay. So although DDD costs are not as accurate as your institution's internal accounting system, so it's just directional in nature, but it's been demonstrated to be within 15% of actual costs. And then we also, our analytics team, update this every so often.
They even update, like when all those new therapies were coming out for COVID, right? All the biologics. This is not just an annual update. Like as new drugs are added into, into the, what's the word I'm looking for?
Formulary.
Thank you. Then that, Vizient is updating that too, to be reflective of our members having new drugs available.
And these are the use case scenarios for the defined daily dose. Again, if you're looking at a population that you're using a lot more of the clinical resource versus a compare group, you can find an opportunity there. If your organization is using a drug for an extended period of time versus the comparison group, again, you could find an opportunity there. And then the same with more IV versus oral. As you know, IV drugs are more expensive. And then here's a screenshot of the DDD table. It provides you with the daily dose dollar amount for each drug. Again, it's available in our learning center. Now we're going to get into resource manager reporting. Let's see. Quickly go through this. Like any other reporting we have the Report Express that's Vizient generated and Report Builder that you can create on your own ad hoc reporting. And so let's start with the Vizient generated reports. And this is the one that we mentioned earlier, that the report release and data submission. If you hit, for example, I don't have the new one here, but if you hit the very first due date there at the top, you will fall into cadence. So like, for example, for Q2 2022 data, if you meet the July 29th deadline, you'll be able to see your Report Express and Report Express Resource Manager reports and your clinical documentation reports. So just know that anything in Report Express is a snapshot of time, a snapshot of data. And here are examples of those pre-generated reports. And there's a section, there's a header called Resource Manager. Resource Manager reports. Usually it's collapsed, but if you just make sure that you expand that to see these listed. If it's not populating, yeah. Again, you'll see 6 select pharmacy reports. There's 5 high impact drug utilization reports, 1 inpatient imaging resource intensity by MSTRG, and 1 lab resource intensity by MSTRG. And then this one of our most popular reports, inpatient drug costs by MSTRG. Again, it's going to tell you compare the cost of high impact pharmaceuticals for patients across MSTRGs with those of other RM participating hospitals. Again, the costs associated here are based on the defined daily dose. And the good thing about these reports, they have this README tab where it will tell you how to interpret the data. So, and then what they do here, as you can see, it's by MSDRG. That purple column right there, that's your variance to the 25th percentile and to the median. So actually the default of that is sorted by the variance to the 25th percentile. So you can see it at the very top, your MSDRG that has opportunity that you can look at. And then the orange columns are your data, and then the teal columns are all RM hospitals with the different cut points from 10th percentile to 90th. They also provide positive and negative variances in the event that there is a clinically appropriate alternative drug to the one listed with positive variance. So you can investigate if this is a formulary difference, for example. So that's one of a popular report. And this is in your KPIs, the same as your lab and imaging. If you want to look at MRIs utilization, for example, you will see the total resource intensity weight compared to the cut points of, again, 25th percentile and median, that purple columns. And then the same as the drug one, you'll see 10th to 90th percentile compared to all RM hospitals. And the orange columns are your data and the different imaging resources, imaging resource categories. And then another popular report is your potentially inappropriate medications in the older populations, those drugs that are harmful to the elderly, 65 years and older, high-risk medications. It will also, there's a tab for service lines to see the highest distribution of those high-risk drugs, which service lines are ordering those the most that are high risk for the elderly. And then you're going to look at the medication classes and then the individual drugs percentages of utilization again. And we have a quarterly view on the left and a annual view on the right.
And those are based off of the Beers criteria. So if you know, if there were a pharmacist in the room, they might know what we're talking about there. But so it's not just Vizient defined, like, oh, we think these are harmful for the elderly. There's Beers criteria that actually defines those drugs, and that's what we base this report off of.
So this is something you can use, like, for example, if you did age distribution by age distribution, and you see that 65 years and older, you have opportunity in their outcomes. You can look at the resource utilization of maybe we're giving them high-risk drugs, for example. So another way of looking at the data, figuring out what's causing your clinical outcomes. And then another popular report is your transition of high-cost medications to the ambulatory setting. So basically, this is just those that can be given in the ambulatory setting. Why are you giving it in the inpatient setting? And that's a cost savings as well. So this is just giving you, again, the MSDRGs with high utilization of those drugs. The same with the, and then it tells you the admission and discharge information as well. Again, there's a README tab for that to help you interpret the results. And last but not the least are the high impact drug utilization benchmarking reports. And these are specific disease states. As you can see, they're all listed here. Liver transplant, aortic valve replacements, kidney transplant, bone marrow transplant, and percutaneous cardiovascular procedures with your AMI patients. So not everyone will have this. If you're not doing liver transplants, you're not going to have data there, or we're not going to give you that worksheet. But this is, you know, those disease conditions that have usually use high impact drug utilization, again, for benchmarking. All right, so now this is how you're going to do your resource utilization in Report Builder. If you have our Resource Manager access, if you click on resource utilization, oh, I'm sorry, I wanted to show you that there's two types related to Resource Manager, the resource utilization and index rescue drug use.
So we're in the drop-down menu in Report Builder of I want to look at. That drop-down menu is where you're going to find these.
If you're not seeing that, that means you don't have Resource Manager, but it looks like you gave everyone Resource Manager. Okay. And when you click on that, the resource utilization reports, you'll have additional by variables. So you're going to be able to use those different buckets, you know, major, sub-minor categories and such. You can also do a bivariate by charge code, by prescribing physician, or route of administration. Again, you're only going to see those bivariables if you select resource utilization report. All right. And then, so this index rescue drug use is also a good one to figure out outcomes or utilization of drugs. This is just a screening tool, actually. There are different pairs, drug pairs, we call it. So what we're looking at, if there's a rescue drug that was given on this same day or anytime after the index drug date of service. Again, it's just a screening tool. We're just looking at pairs. We're not looking at the details of why you gave the antidote, that rescue drug. So examples are opiate and naloxone. Can't say that word.
Naloxone.
Naloxone. And then heparin and protamine in the procedure areas. So those are just examples. And there's only 8 pairs, I think. And then when you use the resource manager, a resource utilization report type, at the bottom, you'll be able to select the all available CRM hospitals. Remember, not everyone are participating CRM hospitals. So just make sure that when you're selecting a benchmark, you're selecting those that that's submitting their resource manager data as well. So you'll have benchmarking group. And then once you select that, there is an additional standard restrictions. The date type, This means you can use the utilization of resources while the patient is in the ICU, not in the ICU or all days. Okay, so that's another standard restriction. And the most important part is your advanced restriction. When you select resource utilization report, make sure that you're also selecting the category. At the bottom here under advanced restriction, you select clinical resources, and then under include only, not include only, I can see. Clinical resource category. There will be different categories there. And then if you want to drill down on the specific resources, what you can do is select one of the categories. Make sure that if you are selecting pharmacy and you're looking at a different drug that's not high impact, that you're selecting the radio dial of all there.
An example of that is aspirin. Like sometimes we'll run, like you might want to run for your cardiovascular line, like how many of our AMI patients got an aspirin on, on their visit. Aspirin is not considered a high impact drug. So if that radio button is not selected and you're like, well, where's aspirin on this list? If you change it to all, you'll find your aspirin. So that's, I guess, a relevant example.
What if all is grayed out?
That's only available for pharmacy. So if you've got another clinical category selected, that's why. Yeah. Did that change it? Okay.
All right. Another thing that there's a radio dial that says cases. Is that it?
This is not.
No,
receiving-
the
oh,
sort.
Yeah.
The code and description. Make sure that so you can see the description. Make sure that you're selecting the description first. If not, we don't know what the code is unless you have the resource manager lexicon as a reference. But make sure that you're selecting the resource and then the high impact for pharmacy. And then the last piece here is the checkbox called cases not receiving. So you can track the percentage of cases that did not receive a drug or resource, for example. And then for this example here, it's selecting a high impact drug of transaminic acid. And then because it's the description is radio dial is selected, now it's sorted by description. It's easy for you to look at your resources.
I love the cases not receiving option. Like again, especially if you're looking at quality reports around some of your standing protocols, right? Did our patients came in with sepsis? Did they get vancomycin? You can look at it. If you check the box cases not receiving, you can isolate all of your encounters that had a sepsis diagnosis. And I don't know if that's a relevant example anymore.
Yeah, it is.
If vanco is still standard of care, but you know where I'm going with this. If you have certain protocols, you can use this, not receiving and receiving option to really kind of identify those cases that fell out.
Which physicians are not ordering what they're supposed to be ordering, for example. And these are just the definitions for the standard columns when you're running a resource utilization report. There's a denominator cases, numerator cases. So the denominator cases, it will give you the total number of cases of what you selected as your patient population in the advanced restriction without consideration of the if they used the resource or not. The numerator cases is that the number of patients who received or utilized the individual resource. Okay. And
This
then
is a really nice reference slide. When you get the
Yeah.
deck, like once you start using resource manager and running resource utilization, it's just, it basically crosswalks you to all of those column headers to know what those definitions are that you're seeing in that output.
Yeah. And then if you're benchmarking, make sure you're looking at that percent clinical population numerator cases. That's a benchmarkable unit because you're looking at the rate rather than the numbers. And then the mean days resource used per case, kind of like your duration of therapy, then total resource units per used. If you that's a total of everything in that patient population of all the resources with that resource intensity. And then resource intensity per unit we also give you. And then resource intensity total weight and resource intensity per case. Okay. And this is the resource intensity per case, again, is a something that you can use to benchmark. And then the only difference when running a pharmacy category report, you'll see the DDD resource total dollar amount instead of the resource intensity. Same with the resource DDD resource dollar amount per case, but they're the same concept, just the pharmacy. All right, so let's see, we have time for a couple of scenarios. All right. So you're interested with MSDRG with the highest opioid utilization? Should we do that? I can share, right? Who's sharing?
I'm sharing.
Okay.
So, yep, so I'll, you want me to go into Builder or do we want to just do screenshots? Might be.
Yeah, we can do screenshots.
Okay.
Is that okay? So now, if we're trying to figure out who, which MSDRG or patient population had the highest opioid utilization, you can run a resource utilization report and then by variable of MSDRG. And follow along if you like. The same concept, we're going to select the time period like you guys did earlier with Jen and your focus hospital. And then here, the difference is when you go to your advanced restriction, you would click on clinical resource. It's so small.
Yeah. That is so small. Can you make it larger? Whoops.
So
So,
under the clinical resource, when you click on that, hover your advanced restriction. Click clinical resource and then choose the pharmacy category in that drop down.
when that new window opens, did everybody get there? Okay.
And then make sure that you are sorting by description. You see how in that right there is by code. And then under the sub minor class, you'll find opioid agonist.
Control find too.
They're alphabetical, so you just use your scroll bar and find your
Under sub.
opiate agonists.
So when you select that, all the drugs within that category will be selected. Okay. And so let's run that by tabular. And when you run that,
Is it there? Oops. Oh, I don't have the output.
oh, because it's, yeah.
Yeah.
When you run that, you'll see the different MSDRGs in one column, and then the DDD resource total in the other column. And that's where we're going to look at who has the highest opioid utilization.
And then you can sort on the column.
Yeah, and then you can sort. And then that's the MSDRG that has the highest amount. So that's something you want to look into. Why are they
I had to guess, if I had to guess, it's gonna either be your
sickle cell?
OB, your ortho.
Yeah.
We tend to see ortho bubble up on that one. Did anyone run it? Were you able to get results? Oh, it did?
Yeah, and then I got it. Then you sort it.
Then you can sort it by DDD resource total.
Who said they had 1,000 rows?
Yeah, it's got. tons
Did you
of
have
them.
it segmented by resource, like individual resource? I wonder if. Oh, okay.
Yeah. All right, so that's how you figure out which patient population you have high opioid utilization. How about chest pain, POA with stress test? Should we go through that, Tennille? Okay, So your quality director would like to know the number of patients who had chest pain present on admission and then had a stress test during the admission. So again, we're going to do a patient outcomes because we're just looking at the number, right? So this time we're just going to do patient outcomes. The same thing you selected earlier. By hospital system is good because we're just looking at the numbers, and then 4 quarters of time frame. You can use whatever time frame, but really I wanted to show you how to select the advanced restriction, which is hover on the advanced restriction. And then again, clinical resource. Oh, I'm sorry, we're going to select the chest pain first. So hover on your advanced restriction, and then diagnosis, and then any diagnosis. Then you can search for chest pain, right? In that text box. So once you search that, it's going to give you selections, all the ICD codes with chest pain in it. Then you can go ahead and select all if you'd like. And then at the bottom, to figure out which ones had a chest pain coming in and had a stress test, you would click on that POA flag and select present on admission. So why?
So you got 4, I got 1.
Oh, this is a screenshot. We were not.
Did you did chest pain as a,
Oh, 4 codes.
I got the wrong version again.
And you typed in chest pain?
the search text, I'll give you guys another tip. The search text is not like Google. It doesn't have AI like, oh, she's trying to say chest pain. She said chest pain. But we don't have that, right? Like it's very literal. It's literally searching for your ICD-10 like string of words. So yeah.
And then now this is where we're gonna select that stress test. So stress test is under the, again, clinical resource. And
So we send this to CBD and then go back?
Yep,
yeah.
yep. So that's one restriction. So you're identifying your population. So we just now said, okay, we want to only see chest pain with POA.
And then now we're gonna add another restriction. So you're there, right?
So hover
and
and
then hover, and then clinical resource. Then this time we're going to use the cardiovascular services category. And the only way you'll know this is when you're reviewing that lexicon, right? So then you're gonna, under subminor class, select cardiography. And then you'll be able to see all the stress tests. So select the stress test. And then
you just look.
found stress test.
So with each of these classes, with each hierarchy you select, it's going to whittle your choices down even more, right? So your minor, when you select cardiography, it only is going to give you certain choices. You could go all the way to subminor class and choose stress test there. You don't have to follow through the hierarchy. You could just go right to stress test to find it too.
All right. So just select the subminor stress test and then add that by clicking OK. And then now you have 2 advanced restrictions, your clinical population of patients who had chest pain, and then those that had stress test. So run that in tabular. And then it will tell you the denominator cases. The first column will tell you those patients that had chest pain, right? The next column. Oh, I'm sorry.
Results. Yeah,
Oh, I'm sorry.
no worries, no worries.
Okay,
If someone else should speak.
all
Yeah.
right. So the first,
I got 11.
you might be using different time frames, so. So your first column will be your denominator cases, meaning those patients who had chest pain present on admission, right? And then out of those that had chest pain, your next column will be your numerator cases and those that had stress tests. And then the next column would be your percent of your percent of your patients who had stress tests. All right. And that's scenario number 2. Any questions on that? Pretty straightforward, right? It's just a matter of finding those minor, sub-minor categories.
Yeah, it takes a lot of just being in the tool in those categories to really start. And you know, again, it's one of those, you'll start to know what you want to look for. And then when you know what you want to look for, it makes it a lot more relevant when you can think of scenarios that are specific to your reporting needs, trying to tie it back to those, you know, certain, you can always identify a population and then you can identify a resource within that population. I think one of your KPIs was around imaging patients with low back pain, patients who present with low back pain, who have an MRI for low back pain, right? Isn't that a metric on a lot of like ACO, you know, all like HEDIS measures? That's the word I was looking for, you know, so you can track that kind of information out of Resource Manager.
So it's the same as how you will select your chest pain patients. You would select low back pain in the diagnosis there.
Yeah, that's
And
one of the
then,
scenarios we have too.
So I was trying to pull some of the stuff for children.
Okay.
And got no data.
No data. And do we know, are we getting charge master and charge level details for children's? Okay.
Can we run that? Let's see.
And that's why I initially did it first and ensured it.
If I don't go all of them. This particular scenario that you did. I got to do the very last step, then I do mention. It's an additional last step, then I go restrictions. Well, when I was doing just under resource utilization. Then. But maybe. She said, see what we're actually.
Yeah, the hospital flag. So I think we'll maybe, I'll look at that a little bit tonight and then we can circle back tomorrow because I want to make sure I'm giving you the right information before I run some reports. I want to do a little recon on that. So hospital flag.
Do you remember what time frame did you use?
A year, Q3 of this year to Q4 21. But I call it like direction.
Got nothing. Okay. All right, so we've got about 15 minutes. What was the plan for the knowledge check? Is that going to be on their time or?
Yeah.
Yeah. Because that's like a survey.
Yeah, we're just gonna go through that.
Okay.
Student teacher kind of thing.
So you want me to get there?
Oh.
Yeah, this is definitely practice. This is like the more you do it, the more comfort level you get with these Resource Manager, but there's a lot of information in there. I mean, that's what's really cool. So what's that?
Gotta know what you're looking for.
That's right. You do got to know what you're looking for. And here's some really good examples in the appendix. Again, you're going to get this deck, but Resource Manager examples. And you can start to pull in your pharmacy colleagues too a little bit and like ask what they might be wanting to look for. And they can get access to the tool and run these reports too. So, okay, here's knowledge check and questions. Should we head there?
That's
Yes.
something that we should talk about at our Medication safety.
Mhm.
meeting.
Oh, you know what? I was able to get numbers for that.
For children.
Low back pain MRI.
No, I was looking at the cardiac one.
Oh, okay. Chest pain, you mean?
Yeah.
Oh, not a lot of, probably chest pain.
We were able to get some if we didn't do all the restrictions.
Okay, maybe it's those diagnoses then, something wonky. Okay. All right.
So the other thing is you have to know what diagnostic radiology means. And
Yeah. So the lexicon here, when you're in resource manager too, that there's in the learning center, the lexicon, kind of orient yourself to that too, because that shows you all the category buckets and like what each of those things are. So diagnostic imaging is basically imaging. It's
But I just got
Yeah.
it. And then you
Yeah,
can control find, and then find that one. All right. So Tennille and Bobby would like to make sure that you, what do you call that?
assess.
Assess knowledge check or questions.
Yeah, let's
We have a
pause.
knowledge for you guys, we'll send out with the slide deck, but what questions do you guys have? And if you don't all the-
Yes, that's top of our priority list. Yes.
Lisa wanted to do the troubleshooting.
She's gonna emulate her. Yeah. For some reason, her drop-down menu is not looking the same as the rest of ours. We're not sure why. In when she's in any diagnosis. Yeah. Special.
It's just a matter of probably clearing the cache, she said.
Okay.
Yeah, we'll talk. Any other questions?
We are. Yep. And we'll include with the scenarios, those step-by-steps for all the scenarios. Yeah. What do you guys think? I mean, has this been helpful, more helpful than the virtual orientation in that we're at least getting a little more deeper in for you all? And
For me, it has.
okay.
That iteration is what I also think has been helpful. I've seen the moves, like the intercept and the beta. What is? Together.
Yeah.
Sure.
Being able to fit together.
Okay. Tomorrow, we're going to cover readmissions. So we'll talk about readmission reporting. I know that's a really hot topic for a lot of places that are tracking that for their, penalties program, for your CMS stars. Like we
so
try to.
did I do the MRI one correctly?
This is where you check it, right?
Yep. So yep, your MRI is fine. Now there might be, the only thing I might say, there might be some other MRI low back. You might want to capture more. It's just a tip. Yeah. Like if we go back. So low back pain diagnosis. So this is saying you had 164 patients with low back pain, and of those 164, 19 had an MRI of the spine, and then that's translated into a percent. So that's 10% of that population.